Invitamos a la profesora Rosa Victoria Castañeda, profesora de la Facultad de Enfermería.
We invite Professor Rosa Victoria Castañeda to moderate
Que tenemos a continuación,
our next session
titulado Estrategias de implementación de
called
navegación
Strategies for the
macro en
Implementation of
Latinoamérica.
Macro Navigation in Latin America.
Para este conversatorio
For this
se
conversatory,
encuentra en el auditorio la doctora María Fernanda Navarro,
we
directora
have
regional
Dr.
para
María
América Latina
Fernanda
de City Cancer
Navarro
Challenge.
for City Cancer
Y
Challenge,
nos
and
acompañan
we
de
have
manera remota
also remote
la doctora Elia Lara,
Dr. Elia
manager de
Lara,
City Cancer Challenge
City Cancer
en
Challenge
León, Guanajuato,
Manager
México.
in
La
Guanajuato,
doctora
Mexico.
Karina, Anaya,
Dr.
médica
Claudia
cirujana,
Karina Anaya,
colaboradora con City Cancer
Sergeant,
Challenge en el diseño
cooperated
e
with City Cancer
implementación del
Challenge in
programa
the design and
de navegación
implementation of
oncológica
the
en el
Oncological
Hospital
Navigation
General de
Program
León y el
in the
Hospital
General Hospital
Materno
of
de
Leon and
Celaya,
the
también en
Maternal
México.
Hospital of Celaya in
Y
Mexico,
la
and
licenciada Marta Ordoñez,
Marta
gerente de programas
Ordoñez,
globales del City
Global
Cancer
Program Manager
Challenge
of the City Cancer
Global,
Challenge
que
globally,
también está
who
en
is
conexión
also
remota.
in remote.
Damos la bienvenida a la doctora María
So
Fernanda
we
Navarro.
welcome Dr. María Fernanda Navarro.
Bueno, después del cafecito espero que tengan
After
ánimos
coffee,
para
I hope that you're in the mood to hear some of the interventions that we have in some of our cities around the world in terms of cancer, and this one in particular about navigation. Who's gonna share the navigation? Perfect. We are looking at that. Okay, let me introduce myself. I'm here. I'm María Fernanda Navarro. I'm doctor of this university. So I hold a master's degree in public health in the United States, and then working at the Dana-Farber Cancer Institute, exactly where Nancy is located, and we met there a few years ago. So now I go back to my country and I work with this organization that will be presented today that is called City Cancer Challenge based in Bogota. And I am the regional director for Latin America of the initiatives and the cities that we work with. Next one.
Entonces, City Cancer Challenge siguiente.
City Cancer Challenge, next. That's perfect. It's an international organization based in Sweden. And we started thinking that we should support the process of the cities to improve the access to quality treatment and diagnosis for cancer, because global recommendations just stay like that, recommendations. And we were not able to actually reach the basis and change how we change those models in practice. And we saw that the perfect ecosystem for this was a city. So we started working in 2017 with cities where we could bring all the others to identify needs, to work around some priorities, and then define specific projects. So we launched in the World Economic Forums in 2017. And since 2017, we are an independent organization that works with all or most organizations around cancer globally, and we bring this technical cooperation to the cities so that can solve those needs that they themselves identify from the basis. A little complex, but quite dynamic and quite interesting. So this is our city network as of today. As you can see, 16 cities in mid and low income cities that are looking for that improvement and that international support in Latin America. We have 7 cities in Africa. We have now 5. In Asia, we have 3 and 1 in Eastern Europe. The cities are not chosen, the cities apply. So this means interest from the city to be able to be part of this network and work. Because if you think, and the first city in joining Latin America was Cali, bringing all stakeholders from Cali is not easy because, well, we have in Banaco, HB, Valle Lili, Mayor's Office, Secretary of Health, cancer population, ICESI, etc. And normally each one of them works in what we have to do, and they do it very well. What we were able to do was bringing all those interests around cancer and putting them to work together, think together to find solutions to the common problems in a common form. And that's how we found paths where they can develop more specific areas as what they did in Cali with the clinical practice guidelines for 5 different diseases, with ways to identify maintenance of the nuclear medicine equipment and other specific work within the cancer continuum. And now we work with the Pro-Pacific, and now you will hear Andres in the navigation experiences in the next talk. Thank you. This is the process we go through. I want to stop here because what's important how we have reached navigation in the different cities. But for you to look at that, this is the commitment of actors. Then is the commitment with the local actors to then define a strategic planning. And then you can see everything that could be done because the needs, as you can imagine, are millions. We need to define where is it that we can start working, and we need to define this strategic planning. So how to define how we start in the mid and long term, and then there is this specific planning that is defined with the local stakeholders. This is like our map, almost the same, but split with the cities. Now looking at the cities where they are in the process, and there we can see Leon, that is one of the cities where we have identified as one of the big priorities and a specific project to work and that has been created. So now I leave you to Marta, that is the one that works with all these programs globally.
Mafe, gracias. Aquí estoy.
Thank you, Mafe. I'm here.
Primero agradecerles
So
no
first,
solamente
I
a
want to
Nancy
thank
y
you
el
not
equipo
only
de
Nancy and the
también
MPI
a
is a team,
colegas
also
y a
my
todo el equipo que está
colleagues
participando.
and the entire team.
Quisiera en un par de
I
minutos
would like
hablarles
in a
un
couple of
poco
minutes
sobre
to talk
por
to
qué
you
ha sido
about
una
why
prioridad para
it has been a
City Cancer
priority
Challenge
for City
navegación.
Cancer Challenge,
Y esta
this
es
topic of
básicamente
navigation.
la pregunta
And
que
this is
estoy
basically
tratando
the
de lanzar. ¿Por qué priorizar la navegación de los pacientes
question
para
that I'm
mejorar
putting on the
el
table.
acceso y la calidad
Why
la equidad de
prioritizing
cáncer?
patient
Esta
navigation to
es
improve
parte
the
de la
access and
misión
quality in
que
cancer
encontramos al
care?
principio cuando Mafe estaba
This is part of
presentando
the
lo
reflection
que
that we saw
hacemos
at the
en las
beginning when
diferentes
Mafe
ciudades.
was presenting
Y
what we
para
do in
esto
the
quería
different cities.
mostrarles la
And to do
primera
this, I wanted
intervención que
to show
hicimos.
you the
Y
first
se trata
intervention.
de Kigali.
And
Kigali
it's about
en
Kigali,
Ruanda. Es
Kigali
una de nuestras
in
ciudades
Rwanda.
de SICAN.
It's
Y
one
ahí
of our
arrancamos con el primer
second
programa de
cities.
navegación.
And that's where we started with
Estas
the
son dos
first navigation
fotos
program.
de los navegadores
These
que
are
fueron
two
entrenados.
photos of the
Pero
navigators
más
that
que
were trained.
detenerme en los detalles,
But more than stopping
fue
in the details,
un proceso de aprendizaje. Y
was
de ahí
a
las
learning
lecciones
process.
aprendidas
And
son las
from
que nos han
there, the
llevado
lessons
a que el
learned
proceso que estamos
are the
llevando
ones that
ahora en
have taken us
Latinoamérica
to the process
sea
that we are
mucho mejor,
carrying
pero
out now
sobre
in
todo
Latin
esté
America is
basado
much
en
better,
lo que vamos a
but
hablar
especially
en los
is
siguientes
based on what we are
pasos.
going to be talking in the next
Quería
spaces.
mostrarles también un par de
I wanted to
documentos
show you
y
also a
herramientas que
couple
se han
documents and
desarrollado.
tools that
La
have
guía
been
en How
developed,
To, básicamente es una
how
guía
to guide,
en cómo
which is pretty
deberíamos
much a guide on
implementar
how we
un
should
programa
implement
de navegación para
the
pacientes de cáncer. La
navigation
desarrollamos
program
en
for
conjunto con la Asociación
oncological patients.
Internacional,
We
la Sociedad
developed this
Internacional de
jointly
Enfermeras
ventured
en
with the
Cáncer
International
Care,
Association
y
of
también desarrollamos esta
Oncological
librería
Nurses
digital
and Care.
de
We evolved
soluciones para
this
navegación.
digital library of
Por
solutions
último,
for
teníamos el
navigation.
curso o el curso
We
que se ha
had
realizado en
a
conjunto también con
course
ISNCC. Es
also
un curso
together with
introductorio y es un
INCC, which
curso
is
que
an
nos ha
introductive
permitido
course that
poner
has allowed
la
us to put
conversación en las
the
diferentes ciudades, en las
conversation
diferentes
in
mesas,
the
para
different
que se pueda
tables of the
discutir
different
qué es la
cities
navegación y
for
por
us
qué
to
es
be
tan
able to
importante
discuss
priorizar.
what navigation is and why it should be a
Y aquí va
priority.
mi siguiente pregunta.
And this
Una vez que
is my
empezamos a
second question.
priorizar la
One, we start to
conversación y se
prioritize
habla de
conversation
navegación,
and we start to speak
después,
about
¿cuáles son los siguientes
navigation.
pasos?
What
O
are
si
the
todo el mundo
next
está hablando de
steps?
navegación, ¿por dónde
If
arrancamos?
everybody's speaking about
Y por eso
navigation,
este,
where should we start?
este
And
proceso que quiero
this is
mostrarles
why
acá
this
es lo
process
que
that I
estamos
want to show you
realizando en las
is
diferentes
what we
ciudades
are
de
doing in the
Latinoamérica.
different cities of Latin
El
America.
primero es un diagnóstico de
First,
necesidades
it's a
que
diagnosis
está,
of
hace parte de todo
needs
este proceso
that makes part of
de
the whole
City Cancer
process
Challenge
of
en
this
la fase
city
número 3,
cancer
en la que
challenge
a través de un cuestionario de
in the
1500
third phase,
preguntas
sorry,
en dos
we have a
áreas
1500
diferentes se
questionnaire
identifican cuáles son
in
estas
two different areas. We
necesidades y cuáles
identify
son estas
the
soluciones
needs and the
que se
solutions
deberían priorizar
that
en la
we
atención
should
del cáncer.
prioritize in
Navegación surge en
caring
casi
for
todas las
cancer.
ciudades. Lo hemos
Navigation
visto
pops
que
out pretty much in every single
las
city.
ciudades
We've
empiezan a
seen
mencionar y
that
empiezan
cities
a preguntar
start
por qué
to
no podemos
ask and talk
implementar
about
ya
this and
navegación,
why
por qué
can't
no podemos
we
arrancar
implement
ya con un
navigation now?
programa.
why can't we start right away with the program? And part of what we have learned throughout these experiences that first we need to have the foundations, which is creating the base through mapping, either through our networks or mapping the patient's itineraries. We are doing this in different cities, and these mapping allows us to identify the specific barriers, understanding that navigation starts as a specific intervention once we know where we want to operate, fighting to eliminate these barriers. Once we have these two elements, we can move forward to the third element, which is the design of a navigation program. And I want to be emphatical here, make emphasis that this program needs to be specific for the context and for the existing resources of whatever city or institution. So taking this into account, we can move forward to the case study. I would like to tell you a little bit about León, what's been done in León, in Guanajuato State, in Mexico. And we will proceed with Elia Lara, Dr. Elia Lara.
Por favor, doctora Claudia, abre su
Please.
micrófono.
Dr. Claudia, can you open your mic, please?
No, Elia es la que debería mutearse,
Ok.
desmutearse.
Sí, es. No tenía
Elia,
permisos
please
para abrirlo.
don't mute yourself. I
¿Ya me
didn't
escuchan?
have clearance
Sí,
to
muchas
open.
gracias. Bueno, pues estamos hablando de León.
So
La ciudad
we
de
are
León es
speaking
una de
about the
las
city of León.
ciudades
This is
del
one
caso de
of the
City Cancer
cities
Challenge.
of the City
León
Cancer
empezó
Challenge
desde
case.
hace
León
años, en el
started
2019
a few
empezó a
years back
participar y en
in
2020
year 1919,
formaliza
started to
su
be a part of this
participación
in
directamente
2020
con City
and
Cancer
start to
Challenge.
partake formally
Es así que, si
um,
quieres, me das la
with a
siguiente
City Cancer
diapositiva.
Challenge.
Estamos
The
hablando
next
de una
slide, please.
ciudad
We are
que tiene
speaking about a city
aproximadamente 2
that
millones
has
de
about
habitantes,
2
en donde
million
toda la
inhabitants, where
infraestructura y el
all the
ecosistema para la
infrastructure
atención
and the ecosystem
oncológica
for
estaba,
oncological care
que el
was
entendimiento del sistema.
inarticulated.
En México tenemos un
So
sistema
we have a
multifragmentado,
system that is highly
multisegmentado,
fragmented
y en donde es
with different
difícil darle
segments
continuidad
in
a la
Mexico,
atención
where
a
it's
los pacientes.
tough to do the proper
En el
follow-up
proceso
of
de
the patient's
incorporación de la
attention. So in the
ciudad,
process of
como ya lo
incorporating the
mencionaron
city, as
tanto Mafe como
it was
María,
mentioned
se hizo
before
la
by María
priorización
Fernanda and
de
Marta, we
actividades
prioritize activities.
y la... Creo que alguien tiene...
Doctora, es que
Ahí
usted
me
tiene...
escuchan mejor.
You have
Y
two
por eso está
connections,
haciendo
so this is why you have an echo,
Ahora
¿Me
sí.
escuchan?
a feedback.
Sí.
Yes.
La escuchamos.
We can hear you.
¿Me escuchan?
La escuchamos.
Sí. Perdón. Sí, gracias. La que sigue, por
Thanks.
favor.
Next slide.
Bueno, se trabajó con todas las
We
áreas
were
temáticas que
working
mencionó
with the
María.
different areas that
Se
Marta
priorizaron 26
mentioned.
proyectos en un inicio y en
We
el segundo
prioritized
semestre del
26
2024
projects, and
iniciamos
in the
con
second
todas las
semester of
actividades
2024,
de
we started
implementación de los
with the
proyectos.
implementation
La que sigue,
activities
por
of the
favor, y se
project.
construyó un programa
We built
con la
a
intervención
program
de más de 100 profesionales
with the
de
integration of more
la
than
salud, pero
100
también
professionals of the
personas
health
de la
sector, but
sociedad
also
civil que
people
estaban
of the civil
participando.
society that
El
were
memorándum de
making part
entendimiento, la
of the
manifestación
understanding memo
de
and
que
the
la ciudad iba a
manifestation
participar está
that the
firmada
city
por
would
las organizaciones
be a
y
part
las
of this is
empresas
signed by the
de
organization,
Guanajuato,
the Social
en el
Security
municipio de
of
Guanajuato, una
Guanajuato, the
fundación en
municipality,
la
a
ciudad de León, y el
foundation
Instituto
in
Nacional de
León
Cancerología,
City,
donde
and
ustedes
the
podrían
National
escuchar al
Cancer
doctor,
Institute
el
of
director
Mexico, where
hace unos
you could
momentos.
listen to the
Ellos firmaron el
director
memorándum de
a few moments
entendimiento y al
back.
firmar este
They signed
memorándum
this
se
memo,
constituyen
and when
dos
they
figuras
signed
que
this,
son muy
two
importantes para la implementación de
main
los proyectos. Uno de ellos es el
options
Comité
were
Ejecutivo de
configured.
la Ciudad,
One
en
is
donde
the
participan todos los
committee
actores,
of the
tanto
city and
públicos,
executive
sociales y
committee, where we
privados,
have
que
most
brindan atención
stakeholders,
en algún momento
public
cuando
and
toman
private, that
acción.
deliver attention throughout the oncological attention. And this executive committee is the one that supports the decision and the execution of the projects. We also have a technical committee. I'm not going in further detail, but these takes part directly with the executive committee to orientate and prioritizing the projects and the feasibility of the implementation. Next, please.
La que sigue, voy a hablar
Next,
directamente
please,
al
I'm going to
programa.
speak directly
Y
of the
bueno,
program.
después de una
And
serie de
after a
reuniones, de
series of
trabajo con todos los
meetings,
participantes en la
we
ciudad,
worked with all the
se llegó
participants
a la
in the city. We
realización de un programa
reached
de ciudad.
to the
Este programa de
materialization
ciudad
of the program.
tiene áreas
This
temáticas, no voy a
city
entrar
program
en
has
detalle, lo que quiero decir
thematic
en la idea principal
areas.
es
I'm not going in
cómo
much detail,
se va
but the idea is
construyendo
how
las redes o
we
los
are building
vínculos entre
the
las
links
diferentes
and networks
acciones que
between different
realizamos a
actions that
través
we
de
perform
eh,
through
la
the
identificación de las rutas de los pacientes,
identification
la
of the patient's
identificación de los
routes,
procesos que
the
se necesitan para mejorar
identification
el diagnóstico,
of the
y ahí
processes
tenemos
required
el
to
tema de la
improve the diagnostics.
patología
And
y
here we have
los procesos de sistemas de
pathological
información y bases de
procedures,
datos, el
information,
proceso de
the
gerenciamiento
process
de
of
las redes de referencia de
managing,
los pacientes, que
and
es
the
un elemento
networks of
más
reference
para
of the
la
patients, that it's
navegación.
a key element for
Y en un
navigation.
principio,
And
navegación no
also,
había sido
for
priorizada
starters,
por la ciudad de
navigation
León,
had not been
había
prioritized by
sido
the city of Leon.
pensada
It
para un segundo
was just
momento.
a
Sin
thing
embargo,
for a
la
second
ciudad
moment.
está
However,
creciendo
the
en el
city is
desarrollo de los
growing
proyectos.
in the development
Uno
of
de
these
esos proyectos
projects.
que es la
One of
base,
these
digamos,
projects,
es
which is the base,
la vía del tren en
is
donde tiene que
the
soportarse la
the
navegación.
train,
Es la creación del
the main
mapeo
train
y la
for the navigation is
identificación de
creating the
pacientes. Este
mapping
es un
and
trabajo que
the
está
network
siendo
of
realizado por
referrals.
todas las
This is a job
organizaciones
done by
públicas y privadas de la
the
ciudad,
public
incluyendo
and
también a
private
las redes
organizations of the city,
académicas, para
including also
construir
the
y
academia,
documentar ese
to
proceso.
build and document
Otro
these
segundo
procedures.
elemento que
A
nos
second
permitió
element
pensar
that
en
allowed
navegación
us to
fue
think
la
about
creación
navigation
de
was
vías
the
integradas
creation
o
of
vías de
integrated
atención integral, que están pensadas
pipelines
en este momento
that
para la
are
atención
thought
oncológica de pacientes
for
con cáncer de
oncological
mama,
attention
pero que
of
está
patients with
desarrollando
breast
todo
cancer
el
that
proceso
is
de
been
la
involved throughout
identificación
the
de
process of
pacientes a partir
the
de rangs
identification
4 y
of
5
patients
y el
from
componente o el camino
levels 4 and
gerencial
far, or
que
the
tenían que llevar
pathway
hacia
that
la
they
atención
had
en
to
un
take
hospital que ya tiene el
toward
trabajo
attention on a
conjunto y
hospital that
multidisciplinario de
also
todas.
has
Lo que nos
a
estaba haciendo falta ahí
multidisciplinary team
era el
in
vínculo
position.
con
What we were
la
missing was
navegación.
the link
¿Qué estaba
with
pasando
navigation. What was
en el
going
proceso
on
o en la
in
documentación de
this
todos los
process of
procesos? Pues
documenting
se requirió
these processes?
entonces
We required
que la ciudad
that the
determinara como una
city
prioridad la
could determine
navegación.
as a
Y esta
priority
experiencia
that
ha sido
navigation
maravillosa
is a
porque
priority. And
no
this was
solamente
a
está
wonderful
participando
experience because
la ciudad
it,
de León con las
it's
instituciones
not only
públicas y
about the
privadas,
city and
sino que
public
se están
institutions and
construyendo
private institutions,
comunidades de
but we are
aprendizaje con el
building
Instituto
learning
Nacional de
communities with the
Cancerología,
National
que es
Cancer Institute,
nuestro experto
that is our
acompañante
expert
técnico, pero además
technical
Special
partner,
Navigation, que ha
but
formalizado la actividad y la
special navigation that has
colaboración
formalized the
para
activity and the
acompañar a los equipos de
collaboration
la
to
ciudad en el
accompany
desarrollo de
the
programas.
teams in the
Entonces
city
voy a darle
in
la
the development
palabra
of these
ahora
programs. So
a
I
la
will
doctora Claudia
hand the
Karina, que
floor
está
to
liderando
Dr. Claudia Karina,
uno de los
who is
programas en la
leading one
ciudad
of the
que
programs
tiene una
in the
visión
city that has a
completa para incorporarse en estos
holistic vision
diferentes
to be
proyectos.
incorporated in these
Adelante,
different
doctora Karina.
projects.
Muchas gracias.
Thank
¿Sí
you
me
very
escuchan bien?
much. If can you hear me well?
Bueno,
Perfectamente.
Yeah, perfectly.
¿se escucha bien?
Perfecto.
Yes,
Gracias.
perfectly.
Bien, yo les voy a hablar acerca
I'm
del
going
diseño del
to
programa de navegación
tell you
de
about
León,
the design of the project
Guanajuato.
in
Comenzaré con una
León, Guanajuato.
frase
I'm going to start with a
dice más o menos
phrase
así.
that says
Dice que
more or
hablar de un
less that
diagnóstico
speaking
es
about
hablar
diagnosis,
detrás una historia,
speaking
pero
that there
detrás de la
is a
historia
history
también hay
behind, but
un
behind every
camino, el
history
cual
there
puede
is a
cambiarse.
pathway that
Mi
can
nombre es Claudia
be
Anaya Moreno.
changed. My name
Vengo
is Anaya
orgullosamente de la ciudad
Moreno.
de Guanajuato, acá en
Hello
México.
from
Y
Guanajuato,
todo este
here in the
contexto que nos ha
Guanajuato state in
dado
Mexico. In
la
this
doctora
context,
Elia,
that Dr.
Martí,
Elia Martita
ha
Mafe,
ayudado al nacimiento y al surgimiento
it
de
has
este
helped
programa, el diseño
to
del
the
programa de navegación
birth of
en
this
Guanajuato.
program of
Y hablar de ello,
navigation in
la
Guanajuato.
siguiente,
And
por
speaking
favor,
about this,
es
the next
hablar
slide, please,
acerca de
is
un
to speak
proceso continuo
about
de
a continuous
aprendizaje, de
process of
colaboración, pero
learning
sobre
and
todo de una
collaboration, but
reflexión
most of
profunda
all, of a
acerca de los
deep
procesos que
reflection
llevamos para la
about
atención oncológica
processes
en
that
nuestro
we've been
sistema
carrying out for
nuestro sistema de salud
oncological
en Guanajuato,
care
pero también
within
tenemos que
our
nos
systems
preguntar
of
cómo
Guanajuato, but
estamos
it
acompañando a las
raises that main
pacientes
question: how are we
que
accompanying
viven con cáncer. Y
patients
todo
that live with cancer?
atendiendo
que queremos
taking
cambiar y
into
queremos
account
sobre
that
todo
we want to
mejorar la calidad de
change
la
and
atención.
improve
Este
the
proyecto
quality
tiene
of
tres objetivos
attention and care.
importantes.
This
Bueno,
project has
un
three main
primer punto, ya lo
objectives.
comentaba la
One,
doctora
first
Elia,
point that
esta
was
comunidad
commented by
de
Elia, this
aprendizaje nos ha
community
acompañado a lo largo
of
de
learning
esos
has
primeros
been
pasos
with
que
us
hemos
throughout
dado
these
en el
first
diseño del
steps that
programa de
we've given in
navegación.
while designing the
Este proyecto
program.
contempla el
This
desarrollo de
project
dos programas
contemplates the development of
en
two
dos estaciones de
programs
salud en el
in
sistema
two
de salud
different
en
institutions
Guanajuato, que es el
in
Seguro Social,
Guanajuato,
por
which
sus
is
siglas en
Social
inglés, y el otro la
Security,
Secretaría de Salud.
and the other,
Y el
the
tercer
Health
punto y la
Secretary. And
meta
the third
final de
point
este
and
proyecto
the
es lograr la
final goal of this
implementación
project is
y ir
to
un poquito más
manage the
allá. Voy a
implementation and
seguir
go a
pasando
little bit
la siguiente,
beyond.
por favor. Les voy
Next
a hablar
slide, please.
ahora de los
I'm
primeros
going to
pasos
talk
que
to
hemos
you
dado.
about
Se
the
llaman
first steps
primeros
we've
pasos
given.
porque hemos
These are the
preparado
first steps
un
because
trayecto
we
muy
have
claro con la compañía,
gone
esta comunidad de
through a
aprendizaje,
way, of
donde
course,
participan
hand in
distintos
hand with the
profesionales que nos han
community,
compartido
with
sus experiencias,
the
pero
different
también han sido la semilla
experts,
para que nos
but it's
ayuden
also been the
a dar
seed
cada uno de los
of
pasos en
inspiration
este
for
proceso.
us to
En el programa de
encourage
navegación,
us.
la
The
Secretaría de Salud
navigation
ha
project in the
considerado
Health
dos
Secretary has been
hospitales,
considered in
Hospital Médico,
two
Hospital General de
hospitals
León
main,
y Hospital General Celaya,
General
para
Hospital of
darles
Leon
seguimiento.
and Celaya
Como
Hospital,
comentaba la doctora Elia,
where,
cuentan con la
as Ella was
infraestructura
saying,
y los
have the
instaladores para
infrastructure
atender a los pacientes con
to
cáncer de
care
mama, que es
for
el cáncer que hemos
breast
seleccionado
cancer
para hacer nuestra
patients, which is
intervención.
the
Hemos
cancer that we
conceptualizado su
prioritized. We've
importancia,
conceptualized the
dado
importance,
que ocupan los
given
primeros lugares
that
en la lista de cánceres
they
de
have the
nuestro estado, en
first
nuestra
place in
población,
cancer lists
pero
of
también
our
hemos
population, but
identificado
also we
maneras
have
de la
identified
atención a la
in
ruta del
what
paciente con
stage of the
cáncer
attention of the
queremos
route
abordar o queremos
we need
intervenir con
to
estrategia de navegación.
intervene with
Cabe
the
señalar que esa
navigating strategy.
iniciativa ya
We
ha sido
need to
propuesta
point
a
that
autoridades
initiative
tanto
has been
directivas de los
proposed
hospitales
to
como su
be
secretaria de salud
directives,
y ha sido aprobada.
the
Es
health
importante
secretaries, and they've
señalar
been
que
approved.
este
It's
proyecto,
important to
esta primera
point that
iniciativa o programa
these
piloto
first
lo hemos
initiative
planteado
or this
utilizando los
pilot,
recursos
we
disponibles de
have
renta
been
libre
done
del hospital
using the available resources
para
the
que pudiera
hospital
ser
has
aprobado y para que
for it to
pudieran
be
tener este
approved and
impulso
for
de
it to
apoyo
have
regulatorio. La
this
siguiente, por favor.
impulse. Next slide, please.
Una parte importante, como ya
A
les
very important
comentaba, de
part,
estos
as I was
primeros
telling
pasos
you,
es
of these
poder
first
mapear
steps
la ruta
is
del
to
paciente que
map
sigue
the route of the
las
patient
pacientes que tienen cáncer de mama dentro del
that
sistema de
has
salud.
breast
Hoy
cancer
esta
within
comentaba
our
también
health
hoy en la
system.
mañana el doctor Arrieta
And
que
as Dr.
hay
Arrieta
unas
said
brechas en
before,
todo este
there are
transitado de las
several
pacientes,
gaps to this
entre ellas el
transit.
intervalo prediagnóstico, una
Uh,
parte
the
importante,
interval
intervalo de
before
diagnóstico, incluso intervalo de
the
tratamiento, la
diagnose and
etapa en la
the
que queremos
start of the
intervenir,
treatment,
no
the
porque nos
stage where we
sentamos
want
como
to intervene,
importantes,
not
sino
because
porque los
the other are
hospitales
not
que
important,
estamos
but because the
participando creemos
hospitals
que
that we are
contamos con
taking
las
part of,
herramientas
I believe
disponibles
that
para el
have
momento para poder
the
crear
tools in order
y
that we can
desarrollar este
create
programa
and
para crear
develop this
evidencia
program to
que nos
create
ayude a
the
que este
evidence that
programa
will help
sea
us
parte de la
make
institución,
this
parte de nuestro
program a
sistema
part
y que
of
también
the
pueda hacer
system, the
referencia
institution
para
that may
aplicarse a
be
otras
a
partes
reference to be applied
del transitado de cáncer, pero
elsewhere,
también a otro
but
tipo de cáncer, y
also
no solo esos,
other types of
también
cancer,
podría
and
ser
not
de
only this,
referencia
but that
a
can
otras regiones.
serve as a reference
Entonces, la
for other
siguiente, por
regions.
favor.
So the next slide, please.
Los alcances que hemos considerado hasta el
The
momento es
scope
reducir el tiempo de
is to
diagnóstico en esa fase de
reduce the
intervalo
times of
diagnóstico
diagnosis
para
in
hacer un
this
diagnóstico más
phase
oportuno.
to
Actualmente se
be
considera que desde
more
la paciente que tiene diagnosticado
opportune with
mastografía
these
colorectal cuadro
diagnoses.
5 hasta que llega a su
Uh,
primera consulta con
Ever since they are
oncología
diagnosed,
para
when they go
determinar
to the
el
first
estadio de la enfermedad
consultation of
puede pasar
oncology to
máximo
determine
hasta
where
8
the illness
meses.
is,
Entonces queremos abrevar este tiempo porque
this can
creemos
take
que
up to
tenemos
8
un
months.
elemento clave y
We know
esencial
that
para el
time
diagnóstico y
is of the
tratamiento
essence,
de las
and
pacientes
we
con
need
cáncer
to
de
be
mama.
more
El
effective
modelo que
in
estamos
this breast
considerando es un
cancer
modelo de
issue.
navegación
The
híbrido,
model
es
that
decir,
we
estamos considerando
consider is a hybrid
personal
model
clínico,
of navigation
tanto
with
como no clínico y no clínico. Estamos
clinical
considerando la
staff and
participación de
non-clinical
personas
staff. We are
voluntarias.
considering the
Ambos
participation of
hospitales cuentan
volunteers.
con un patronato, ya
Both
cerramos
hospitals
sesiones de
have
puertas con
this
apoyo
figure.
de la
We
doctora
have
Elia de
already
salud, porque
knocked
sí,
some
entonces
doors with
se van a
Elia
incluir
support. They
dentro de este
told us,
programa.
yes,
Este
we
programa
are
estamos
about to
considerando
incorporate them.
llevarlo
This
a cabo
program, we are
durante
considering
6 meses y
to
esperamos
perform it for
iniciarlo
6
al
months.
inicio del
We expect to
2026.
start
Los perfiles de
by the
navegadores que
beginning of
estamos
next
considerando
year.
son médicos,
We are
personal de enfermería,
contemplating
trabajo
doctors,
social como el
social
principal
workers,
empleador, pero
nurses,
creemos que todo el
and
personal
however, we
que
believe that
participa en la atención,
most
en el
staff that
flujo de
will
atención
take a
dentro del
part
hospital es
in these
importante
flux of
conocer
attention within the
los
hospital,
conceptos
it's important to
esenciales y
know
básicos del
the
programa de
key essential
navegación
concepts of
para
communication program to facilitate and bridge the barriers of communication and most of all the process. We expect to attend at least 20 patients a month, and the criteria that we define is that the patient should be a resident of León and Celaya, all the ages, and that they have a screening result already for 4 and 5 degree. And next slide, please.
¿Qué esperamos lograr con este
We
programa?
expect, what we expect to achieve with this, we expect, as I said, improve the times of oncological attention. We improve the quality of the experience of the patient, but most of all, we want to manage these first two objectives to identify and eliminate barriers, that these can be a model that we can implement in other places. We believe that we need information and evidence to present to the authorities that we can manage to integrate this to our health programs nationally. Next.
Hablé de que iniciamos primeros pasos,
So,
quizá el
the first
trayecto ha
steps,
sido breve, el que
the
llegamos hasta ahorita.
trip
Sin
has
embargo, en
been
todo este
a rather
trayecto
fast one.
podemos
However,
destacar
in
dos aspectos
all
muy
this
importantes
journey,
que han
I
sido
can
esenciales, que ha sido
outline
el
point two
impulso,
key
que
elements
seguramente
that
nos van a
have
llevar de la mano
um,
para lograr esa
been
meta o
key
ese
to
fin
us,
último. Y
that will help
hablo
us
de la
achieve our
aprobación y
goals. And I
respaldo en las
speak
autoridades
about the
sanitarias,
approval
lo cual ha
and the
sido muy
backing of
importante
sanitary and
para
health
la implementación
authorities,
y para el desarrollo de este
which has
programa.
been key for the
Creemos que es un
implementation
paso
and the
para
development of
importante
these
hacia el
programs.
modelo
It's an important
escalar
step
sostenible
toward
que tanto anhelamos.
scaling
El que las
this
autoridades
model
sanitarias
um,
nos apruebe
that
y que
we
crean
are
esta
approved and that the
iniciativa
authorities
habla de
believe
la pertinencia
that
y
this
habla de la
initiative is
confianza
good.
de
It
poder
speaks about
contribuir a la transformación
trust and
de la calidad
contributing
de la atención
through
continua de la paciente
the
oncológica.
transformation of
Por otro lado, también
the treatment
resalto
and the
muy
attention for
importante
oncological
que
patients.
este
It's
viaje,
very
aunque
important
al
also
principio
that this
sabíamos que
journey,
era una gran
even though
travesía,
we
pues no
knew it
estamos
would
solos,
be
tenemos a la
long,
comunidad
we
de
are not
aprendizaje que se
alone.
ha
We
creado,
have the learning
que nos
community
acompaña
that
con
we
sus
have created
experiencias. Es un programa
alongside
muy
us
enriquecedor
with
y
all
nos
their
orienta de la
experience,
mano
and it's
el
been highly
camino.
enriching, and
Y
they've
hablo
set the
también de
course
la
for
colaboración que ha
us to
sido
go.
piedra
Also, the
fundamental con
collaboration,
City
it's been
Cancer, que me ha facilitado
with City Cancer,
coordinar
it's been
estos
an
proyectos, sobre
important
todo
pillar
porque ha logrado que este enfoque
because we
internacional
managed
se
that
pueda
this
adaptar al
international
enfoque
focus
local
can
sin
be
perder de
adapted to
vista las
local
necesidades
concepts
de la
without
población.
losing
Y
focus
pues
of
creemos,
the
como ya lo
population's
mencionó
needs. And we
Fernanda,
believe, as we
que
mentioned
este programa puede ser
priorly,
de
that this
referencia para
program
una
can
réplica
be a
estatal,
reference to
nacional y
replicate
también,
this
como lo
on a
comenté,
state,
para otros
national,
tipos de cáncer
international
incluso.
level, also
En
for
otras
other
brechas
types
que
of
hemos
cancer
identificado en la
and
misma
other
ruta de
to
atención de
filling
paciente
other
cáncer de
gaps that
mama.
we have identified
Pues
in the root
concluyo
of
diciendo que el
breast
programa
cancer
piloto
treatment.
de navegación
I
oncológica
conclude
es
saying
una
that this
inversión en
pilot
vidas
program is
y en calidad del
an
sistema de
investment
salud.
in lives and
Esta visión
quality of the health
compartida
system.
creo
This
que es
shared
la
vision, I
semilla o el
believe,
impulso
that
para
is the
continuar y llegar
seed
a la meta
we need to
juntos, porque a veces
persevere
navegar
and get to the
solos no es lo
goal
mismo
together.
que
I
navegar
believe
con
that working
compañeros.
alone is not the
Pues
same that
nosotros
working
que estamos en el
together.
diseño del
And
programa,
us that we are
construimos y
designing the
lo
program, we
sentimos.
live this
Gracias.
and we feel this. Thank you very much.
Muchas gracias para el grupo que ha venido
Thanks so
haciendo
much for the
esta
group that
propuesta y
has
este trabajo tan
been
importante
working in
con el
this
City
very
Cancer Challenge.
important program with the City Cancer
Nos acompaña en la
Challenge.
moderación la profesora Rosa Victoria, pero también
Professor
está la
Rosa
doctora
Victoria
María
is
Fernanda
moderating. We have
para
Dr.
las
María
preguntas del
Fernanda
público.
for
Mientras el
whatever
público
question
se anima a hacer
our
preguntas, bueno,
attendees
tenemos
may
unos
have.
minuticos.
We have a few questions for
Voy a
Q&A.
hacer dos preguntas
I'm going to make two
que enviaron
questions that
al chat.
were sent via
Y
chat.
son, ¿cómo se
And
puede
are,
postular
how
una
can
ciudad para
we
participar en el programa del
propose a
City
city to
Cancer
be a part
Challenge?
of the City
¿Y qué
Cancer
actores de
Challenge
la
program, and
ciudad
what
se deben postular?
stakeholders of the city should be a part of this?
Me encanta esa pregunta. No es de
It's a
navegación,
good
pero sí
question.
es una
It's not
oportunidad.
about
Y
navigation,
gracias al que
but
lo
it's an
hizo.
opportunity, and
Ojalá
thanks
sea un país de
to
Centroamérica,
whomever did
porque
it.
son
I hope
las
it's a Central
ciudades que nos
American
faltan.
program
Tenemos
person
pues
inhabitant, because
México,
we are missing these cities.
ya
We already have
está
Mexico, that
Perú,
it's
Colombia,
huge. We have
Brasil,
Peru, Colombia,
Paraguay,
Brazil,
Argentina,
Paraguay,
Chile.
Brazil,
Entonces
Argentina, and
nuestra
Chile,
digamos, falta.
but
¿Qué
we
puede
are
hacer?
still
Y han
missing
dicho City Cancer
presence in
Challenge
Central America.
en las
So
redes.
what could this
Nosotros
mean in the
abrimos
network?
convocatoria
We
en algún
open
momento y
callings and
ahí están
calls
como las
in
características, como
any
no hay
single moment.
ONGs,
We have
sociedad
the
civil que
guidelines there,
aplica.
but
No buscamos que sea el
it's not
gobierno,
the civil
pero sí debe
society
haber
who want to apply
cartas
it.
del
It's not a
gobierno
government,
apoyando la
but we
aplicación
need
porque
endorsement by
obviamente el
governments, of
gobierno tiene
course,
que ser
because the
voz de
government
oposición,
needs to
pero
be
son
a
representantes
key
más de
decision
un
maker,
rol
but
que
they represent
representantes
more the
funcionales.
role
Digamos, la
than
Secretaría de Salud
personal
hace parte del
representatives.
comité
Health
ejecutivo de
secretaries
Cali,
make part of the
pero
executive
cuando cambia la
committee
secretaria,
of
pues
Cali, but
llega
when the
el nuevo
secretary
secretario a hacer
changes,
parte
we
del
have a
comité
new
y no la
secretary
misma
makes
secretaria
part of the
que
Camera
como
of
para que no sea
of
politizado.
Cali.
Entonces,
So
más o
we
menos
avoid
cada 2 años se abren
you know,
convocatorias para las
politics in
ciudades
this case.
y la
And
característica
the
es que tengan
characteristic
más o
is
menos
that
1 millón de
they have
habitantes
at
y
least
tengan ganas.
1 million
En
inhabitants
este
and that
momento nos
they
pueden
want to
contactar,
work.
nuestros datos están
That
ahí,
is
cualquiera de
all that is
nosotros les
required. You can
puede
contact
dar
us.
información
We
y
can give
estaremos
you
felices de
information and
darle la
we'll be
bienvenida a más
glad to
ciudades en Colombia.
welcome more cities in our
Muchas gracias,
region.
doctora María Fernanda.
Thanks,
Aquí
María Fernanda, we have a question from Mexico. Good afternoon. I am from Mexico, but I have a foundation and I just signed partnership with a Rosa Union that makes part of the whole state of Mexico. How could we applicate? I have several alliances because I don't agree a lot with my government. Of course, we need to abide with permissions. Don't worry. I'll look after you after we are done with this, and we'll have a chat after. Okay, thank you.
¿Tenemos otra pregunta en el público?
Do we have any other questions?
No hay más preguntas.
No further
Bueno,
questions.
yo le quiero hacer
So
una
I would
pregunta
like to make a
la
question
doctora
myself
Fernanda,
to
y
María
es,
Fernanda, Dr.
solamente
María
pueden
Fernanda, and it's
participar
the only ones that can be a part of
en este challenge
these challenge can only
países,
institutions,
o también
countries, or also
fundaciones,
foundations
programas,
or
que
programs
pronto estén
that
trabajando
may be
con
working
cáncer en comunidades.
with cancer in communities. Our core are cities in the world, because we realize that methodologies work if you involve all the stakeholders to work together. There were a couple of slides that were interesting that may not be meaningful for us as Colombians, but in Mexico, see the logo of LIMS next to the health secretary working on a program hand in hand. It's very powerful and very meaningful. It means that we overcome the barriers in terms of the health system, as Elia said before, that's highly fragmented. In Argentina, we see the same. We see the privates working with public health system, and this is rarely seen. They have the same problems, but there are few moments where they can work together. So to answer to your question, we work with specific cities, and the process is a very careful one. It's a bit long, and these cities feel, well, the benefit. This is why the application is not so simple, and we don't have that many cities. However, city challenge is open to all technical cooperation. We work with International Atomic Energy. We work with the World Health Organization, where we apply the Global Breast Cancer Initiative programs that was launched 2 years ago, and we bring them to the city. So it comes from two different parts. Once again, I can give you my email. You can contact me. I am based here in Bogota. I speak Spanish. I am easily accessible. If you have questions, or if you want to see areas or we can find synergies, most of all in what Marta was saying in Kigali, Rwanda, this is with organizations of the civil society that handle navigation subjects. Thank you very much, María Fernanda. May I contribute a little bit?
Gracias. Si recordamos la
If
diapositiva que
we
presentó
remember
Elia
the
del
slide that
programa,
Elia presented of the city program,
debo hacer un
and
énfasis en
I
cómo
like
ha
to
sido
be
repetitivo
emphatic
que
that this has been
navegación es la
repetitive,
respuesta
that
a
navigation
muchos de
is
los
the
problemas que
answer
encontramos
to
de
many
las
problems
ciudades.
that
Cuando
we
hablamos con
have
los
in
patólogos,
our
los
cities. When we
patólogos
speak
dicen,
with
es que necesitamos un
pathologists,
programa de
they say it in the
navegación.
things that we
Cuando
need
hablamos con los
navigation program.
cirujanos,
When we
la
speak with
primera
surgeons,
solicitud
the
es el
first
programa de navegación.
thing that pops
Entonces,
out
se
is the
está
navigation
volviendo
program.
una
So it's
solicitud
becoming
repetitiva
a
de cada
repetitive
uno de los profesionales de salud
demand and
y de
request
los
of
médicos
these
en el ambiente
professionals
oncológico,
within
aún más,
oncological, this
no solamente el
oncological
éxito de
environment, that is
navegación, sino que
acknowledging
están
not just
reconociendo que la
the success of
intervención
navigation, but
funciona
that
cuando
are
está
acknowledging that
integrada a la
the
red,
intervention
cuando
works
está
when it's
integrada al
integrated to the
proceso
networks,
multidisciplinario,
when
cuando está
it's
integrada
integrated
al
to
laboratorio.
multidisciplinary
Las navegadoras
workflows.
deben estar sentadas
Navigators
en los
should
comités de
be
tumores.
there in the
Y por eso es que
tumors
dentro de los
committees.
proyectos
And
que
this
están
is
corriendo
why
paralelamente,
in our
al mismo
parallel
tiempo que se está
projects,
creando una cultura de trabajo
at the same time that we are creating a
multidisciplinario, nos estamos asegurando que los
multidisciplinary
navegadores
culture
están
of work, we
sentados
are assuring
bien, o
that
los
our
navegadores, perdón,
navigators
en el caso
are
de León
present
también hay
there.
navegadores,
And
habrá
in
navegadores
Leon, we have
profesionales.
female and male navigators
Entonces,
present
creo que es muy
in this committee.
importante
So I believe that
reconocer
it is
cómo se
very
está
important
creando
to
una
acknowledge how
conciencia de
we are
navegación
creating
e
awareness
intervención, no
in
solamente
navigation awareness
eficiente,
uh,
también eficaz dentro del
as an
sistema de salud, pero que es una respuesta a las
intervention that is
necesidades
the answer
de
to the
muchos
needs
profesionales en la
of
atención del cáncer.
many professionals working in the cancer topic. Thank you so much. Thank you very much. I believe that this is the panorama that we have of oncological attention that has equity and quality. I thank Dr. Navarro, Dr. Claudia Karina María, and Martha Ordoñez. They show us how is to work as a network, and this is what we need to do. We always talked about interdisciplinary work, but what does this really mean? What does interdisciplinary means or transdisciplinary means? The reality is that we are stronger together. This is a way to visualize how we can work with oncological patients because we know the problems they face, what it represents to us, the challenges of an opportune diagnose, and we manage this bit by bit. And with this new navigation model, as impactful as it is, I believe that we will have even better results. So thank you very much to our speakers. It was excellent work. Thank you very much. Thank you very much. And María Fernanda, please, everyone wants your context, please, to share these contacts through the chat.
Y ahora tenemos un invitado
And now
también
we
muy
have
especial.
a guest, a very special guest that comes from Cali. He brought us manjar blanco, which is a local Colombian sweet, with the conference title Economic Impact in Navigation of Patients and Cost-Effective Programs.
Bienvenido.
Welcome.
Bueno, muchísimas gracias.
Okay. Thank you very much. The worst of all is that in reality, I didn't bring you manjar blanco. So sorry. Thank you very much.
Bueno, es un gusto para mí estar acá.
I am delighted to be here. I'm very pleased to be here. I thank very much NPI, Dr. Nancy, and her whole team for having me here, or inviting me. I thank you all for being a part of this event. I am deeply satisfied. I started with this back in the year 2012, and I started with breast cancer topics. I had the opportunity to work with an American NGO in Baltimore, where once we were there, thanks to the support of American Cancer Society, we had the opportunity to try to deliver these patient navigation to Cali back in the year 2013. It was a big adventure. It was not easy, but I would like to speak specifically about colorectal cancer, which is one of the cancers that we've forgotten a little bit regarding others, and that it's well worth to speak about. I'd like to mention
La sesión del día de hoy
today's session
se hace apoyada
is
por parte de Engine, que nos ha
supported
brindado
by
toda su
Engine
colaboración,
that have given us
materiales,
the collaboration
convocación de
for
eventos y
the
demás actividades
materials.
que
The
generar
call for
parte
this
de
event
productos
has
que al
allowed to
final
generate part of the
soluciones
products that by
realizamos.
the end of this session we will show you.
Bueno, el cáncer colorectal es un problema de
Colorectal
salud
cancer,
pública, sin duda. Eso, digamos,
Without a doubt,
eh,
that's
las mortalidades para hombres y
the
mujeres
mortality for
son
men and
muy
women
altas.
are very high.
Sabemos que el país, en Colombia lo
We
tenemos
know
bien
that in Colombia,
identificado.
it's
Quiero
quite well
mencionar que para
identified.
nosotros como
I want to
país,
mention that for us as
analizándonos
country,
en específico, el tamizaje es muy
analyzing in
bueno,
particular
porque ha
screening
dado que tenemos
is
una cantidad
very good.
creciente y al mismo tiempo unos retos grandes
It's a
que
very
todos
big need, and at
conocemos
the
a
same
nivel
time, some
nacional.
challenges in terms of
El
ensuring.
país no se ha quedado atrás en
The
formas
country is not
guías y
behind in terms
recomendaciones,
of
aunque sea un
guidelines
poco
and
lejano, pero se lo
recommendations.
explico. Del Instituto Nacional de Cancerología han
From the
surgido
National
algunos
Cancer Institute,
documentos. Este
there
que
have been
está aquí en
several documents.
pantalla
This one that you
es
see on
una
the
tabla en la que
screen
se resume el riesgo que
is a
puede tener un
table where
paciente
we
para
summarize the risk
colorectal.
that patients can have for
Como siempre les digo a
colorectal
todas las
cancer.
personas que nos visitan
As
afuera,
I
que en
always say,
Colombia
people
no
who
nos
come
quedamos cortos de
in
documentación.
Colombia, we are not short on
Estamos con todo
documentation.
muy
We
bien
are
analizado
very
con
well
datos, tenemos
analyzed with everything.
evidencia científica
We have
en los que cada
scientific
dossier
evidence.
divide
In this case, the risk is split in 3 levels. And for each level of risks, we propose some actions in terms of screening. So should the risk be low, so then we go with a hidden blood. If it's middle high, it has to go to colonoscopy. We know as a country that it has to be done. The problem is for the patient to use those services. When we talk, there is a particularity that I want to use to mention. When we say breaking down barriers for the case of Colombia, we cannot, because if we break down one of the main barriers, quote unquote, that are interpreted for the Colombian health system are the authorizations. But actually, it's not the authorization. The barrier that we have is the time that it takes in managing that authorization. Let's remember that authorization in Colombia is a way to control expenditure in health. Given the characteristics of our system, that's needed. What's wrong is that it takes too long. And finally, patients cannot access what they need when they need it. In that case, I want to talk about the cause of late healthcare. In a study by Carlos Pinzón and other colleagues, it happens that this is little box populi, colorectal cancer, is usually diagnosed late, and that has an important commitment in terms of survival, but it also generates additional expenditure to the health system. In addition to that, it has been said that there is a disconnection in the provision of services for those cancer. And we know that because of its common name, genetic name, fragmentation, system fragmentation, care of the patient can be between the suspect and diagnosis. They have to go through 4 institutions, and what has been evident in the big experience that he has with the chapter in Cali. In this point, patient navigation, patient navigation can play a key role. Patient navigation has shown to be effective, specifically for colorectal cancer. And we have a good indicator that it's well proven, and it's adherence to screening. It has worked, and it can work for us as a country. But what happens? We have a big challenge, and you know it better than we do. I have this year the fortune to be supporting different processes in Cali, Bogota, Medellin. And what I see is that the procedure has never been denied. Colonoscopy is not denied to people. The thing is that it comes 2 months late. The thing is that maybe it never comes. The thing is that for when they get the order, the patient desists because they want to keep going with life and do their own things. And in that sense, the system is failing. But we have to see how we fill the gap between the patient need and the offer of the service. Patient navigation can be one of them. Without a doubt, of course, patient navigation, it's important. So 8 of the 9 studies proven that patient navigation, it's cost effective. And it's a good choice to make patients reach the service they need, but also that they do it for the cost that they need with high levels of satisfaction. And in this, what are we needing? What's missing for us to implement this? Knowing what we know, why don't we do it? And that's a question that I want to also try to. Of course, we want answers today, but I want us to think about it collectively. I will talk about a couple of those studies. One of them, both are for the United States, but one of them says that patient navigation is effectively cost effective. Indeed, if we think about the costs that the disease in the long term can generate, there are studies for other pathologies in Colombia, such as breasts and uterus, where they analyze that the later the diagnosis, the more expensive it will be for the system, and the other way around. The more opportunities we have for on-site diagnosis, actually for breast cancer and in situ diagnosis, is 10 times less expensive than stage 4 diagnosis. Second case is the one that says patient navigation is very few words. Patient navigations for the person to get the colonoscopy saves money, even when you think about the single price of the procedure, because it's not only slightly cheaper, 725 versus 737, but it's been calculated what the patient gains in terms of quality of life and elements. And for this, we know this very well in our context, the out-of-the-pocket expenditure of a patient trying to get a procedure, and what that means in terms of constant visits to the insurer trying to get an appointment, or trying to change some strange word that they don't understand. Like, for example, you have to go to the insurer, because it's wrong. In those occasions, the patients don't understand what COOPS is. And actually, we need to say that for most patients, the difference between an IPS and an EPS is actually a vowel. They don't understand, and they don't have to know it. We are the ones who know it. For us, it's our job. We do it every day, but for them, it's the first time that they face this process of cancer diagnosis. So this is data that we want to share with you, not in a way of as a critic, but so that we can think how we are articulated. And in this case, I want to highlight the work by organizations such as a City Cancer Challenge that generate articulation around common assets. This is what is being gathered information from in a city. I'm going to mention the name, but like Salsa. This moment, the secretary takes the data, and if you analyze them with detail, they sound like random details. Because if, for example, information about men and women from 70 and 75 years old, well, in theory, for screening. So we know that in Colombia, there is not interoperability. Each institution and insurer have their own database. So therefore, that piece of information is good to gather, but that's it. I want to go beyond. So for example, we ask some institutions the number of cases with opportunities for starting the onset, but that is asked to also low complexity institutions. They don't have that information. Thank you very much. They don't have that information either, and vice versa. High complexity institutions are asked about the number of women screened, but the high complexity in Colombia, they very rarely do screening for most cancers for living this margin error. All high complexity is saturated, and the one that is not saturated, it's in aspects associated to insurance, and that for the locals is quite simple. I also want to make a suggestion based on what I have seen in the 3 cities that I have mentioned before. First, as you might see, there is not an indicator that talks about coverage. And here I want to make a final call. The patient navigators cannot be given the task of expanding coverage, because that's not what they are for. What we are for, coverage needs to be expanded by the system. Of course, with EPSs, different strategies, but the navigators cannot do that. So with that exception, I want to mention some indicators and some particular numbers to try to move along in this. First one, it's adherence to screening since low complexity, and also the opportunity until the patient is diagnosed, from the moment it's captured until it's diagnosed. So and that will depend on the capacities of the institutions. The hidden blood sample is easy to get, colonoscopy not so much, because that will require a connection with a higher complexity institutions. Some level 2 hospitals sometimes carry that out, but usually they have to be referred to other institutions. Now, let's not talk about that aspect that I can do here in the blood, but colonoscopy is higher somewhere else. So I want to mention 3 dates that can be everything for the proper follow-up of this diagnostic referral to high complexity and starting with patient navigation in that high complexity. And I mentioned this because in the numbers 6 and 7, when I am going to analyze and I make that suggestion for a high complexity, it happens that if I am going to estimate or calculate opportunity, the patient sometimes have been diagnosed for a month. And that's when I contact the patient and or comes to me. And in that case, the target for diagnostic in less than the 30 days will never be met because that patient has already been for a month going around the system. So we don't connect is reality. Low complexity doesn't talk to high complexity. And we have work to do. But in addition, we have to measure the intermediate dates that are 3, 4, and 5 suggested based on what we have seen that can help us identify from both sides of the provision in terms of IPS, how we can articulate and how we can take the patient a little beyond so that eventually the patient is delivered to the high complexity navigator. So let's talk about Colombian relatively briefly, and let's think, is screening cost effective? Praxis says it does, because we are not measuring that. And, you know, it's a big path to go around. We, as patient navigators, the strategies tied to specific programs, such as the early detection program of colorectal cancer, we are not measuring. And in that sense, we cannot prove that we are cost effective, as mentioned before and very recently by Dr. Nancy. If we show data, you know, we can advocate and we can argue and we will be heard, and we can be a very good scenario one way or another. Yeah, how fast can we react when we have a colorectal cancer case first? Who notifies, who diagnoses, who sends to the high complexity? How is that moving along? You know, it's I mean, do we get a quick response? It depends on the cases. We have a lot of insurers in Colombia, and we have many clinics. And then let's think, it's patient navigation cost effective? Are we doing navigation? I mean, fortunately, patient navigation has a very good reputation. We are working, there's these kind of spaces, there's wellness. We have to think about that, how we can measure cost effectiveness, because at some point we have to say the colorectal cancer has grown a lot. The study is being very welcomed by the patients and the health system. We need to grow, but to grow, we need data. In here, I want to mention something about challenges that we have perceived for the implementation of patient navigation. The first one is the funding. So I have a very personal position that I want to share, and it's, I don't think that carrying the patient navigation into the Colombian health system is a good idea, because what I have seen is that patient navigation optimizes processes implemented so that the IPSs can make the patients to flow faster and be more patient, flow faster with better results. And in that sense, charging navigation to the system could take away that incentive of managing the patients with quality and opportunity. As once I heard somebody talking about this. You know, somebody from vaccine says, but if I vaccine 20 patients, two patients get the same payment that is a vaccine 20. So we have to think about that. Is our system ready for that? The other thing is heterogeneity. We have patient navigation programs to do everything. Sometimes we did an exercise. Last year, we visited more than 20 IPSs in Cali. Everybody had patient navigation. Nobody was left outside. And what we said is, but what type of patient navigation? You know, that you call the patients to remind the appointments. So a very important task, but it's not about patient navigation. So there, we need to integrate ourselves. Integration. We need integration because we require urgently how we stop seeing the system based, thinking about the cell of health services. If I do colorectal screening, it's because I have a defined path about where the patient is going to get. I cannot, and please let's stop doing every time we do this. We do 20 sit-ups. We cannot tell anybody or no patient in case of a diagnosis, go to EPS to get the supply. If we are offering the screening service, we need to get to know what is the network of healthcare for the insurance companies we are working with. We cannot be part of the program. And the last thing that I have about the challenges is the really big expectations that we have about patient navigation. For example, the contract is interrupted, between insurance and there is no patient navigations will resolve, but they don't have the capacity or the power to establish this agreement of patients care provision, that patients don't have the resources to travel. You have to think about that in the macro. The patient navigator can aim at the problem and can try to find creative ways to deal with that situation. But the navigator is not going to be able to solve it. In that sense, we need to think when we say navigator, all of us are navigators, that's good and that's bad because we include the entire team, but it's bad when we say navigation is all of us for the moment of the photo, but we don't understand that navigating is managing solutions for the patients. And that is not done just by one person. We need to work as a team. Finally, I want to tell you that right now I come in representation of an organization that is called Pro-Pacific, that creates bridges amongst different institutions to try to take benefits to the communities in the Colombian Pacific, that also we are talking in different areas of the country. Right now, in this QR code, you have the materials that we have prepared and a lot of willing to share, thinking that they are documents with guidelines and recommendations about how we could do patient navigations adjusted to the Colombian context. We have a general document, but also a document for the standardization of best practices and 3 basic indicators that could help us in this exercise. And also this checklist, so that we think the one that does navigation in the field and the one that requires or coordinates this thing, what should they have on the day-to-day to exercise? It's a task given the context that we have failed. What we want to do is to have a navigation at different levels, always adjusted, but always keeping patients at the center. Thank you very much. So now we are going to share this space with Dr. Andres for the questions from the public. Meanwhile, there is a question that comes via chat, and is what would be the ideal scope of a navigation program for it to be cost effective? Early detection or timely detection. A program that supports patient until what stage or what time of the decision. It depends how many resources do you have. How much money do you have? What's the time available? And what will be the flow of patients? Usually, in Colombia, if there is a lesson that we have learned, is that it's impossible for a navigator to capture a user from the very beginning, from day one, and take it up to the moment of the final treatment and do follow-up 5 years later. That's not going to happen. We don't have the staff to do that. So my recommendation would be to think about some of the critical points, and there is where we can put the patient navigation. In the case of colorectal navigation, the biggest barrier is in diagnosis, particularly associated to the access of patient to colonoscopy and obtaining the results. There are barriers, for example, that the kit preparations are ordered, and those kits have also cost that are not covered by the system. In some cases, there are details, but in other cases, yeah. But this kit that is around 80,000 pesos, so that's like $20, can be little money for some people, but for others it's a lot. So in that case, by not having that, the system offers the colonoscopy, but not the kit, and that's a barrier. And as that, there's quite a few. So talking in terms of colorectal cancer, I would put a navigator between the patient, the suspicious patient that goes to colonoscopy and has to go from that point until we get the negative colonoscopy or positive for the cancer. And in that case, to be referred to the navigators of the institution that will be providing the treatment. Thank you. Dr. Andres, there's another question.
Buenas tardes, doctor Andrés. Yo
Good
quería hacerle una
afternoon.
pregunta.
I wanted to ask you something. In the experience that you have developed in Cali in navigation and understanding the topic of fragmentation, you mentioned very well that topic of the authorization of services as one of the main bottlenecks that we have, and that eventually generates this increase in the time lapse between suspicious and diagnosis. Have you been able to manage that with the insurers? Thinking probably about navigator in the insurer or a case management that can also facilitate that articulation process. And on the other hand, in the case of the non-insured population, migrants, etc., how are you articulating with the territorial entity? Because there are some important bottlenecks from that side. Totally, yeah. When the strategy is presented, the insurer is presented and is mentioned, this is an opportunity for you because it's a moment for those cases that used to get stuck and generate bottlenecks will be managed from an approach of the provision of service for early detection. Always the insurer is involved, and in practice, what we have done is that we, for the insurer, we do have a number that is called authorization, but we have one from authorizations. I got his name, his number. I show him what I'm doing. He tells me what he needs, and we generate its relationship not based in he is the one that is not authorizing, but for him to understand what I'm doing, and for that to be, we try to generate that in some more friendly terms, more cooperation. That is just a request, and like from a negative perspective, we know, we understand that the lawsuits won't do any good, so we have to change the approach. We carry out periodical meetings, and we invite the insurers. We have something that is called the departmental and district committee for cancer control 4 times a year, where we show all the projects associated to cancer. It includes insurers, clinics, of course, the health secretary. And then you already know who is the person from the insurer. We know each other, we know about the projects, and when the authorizations problems come about, they are managed. I cannot say that always immediately, but we have improved a lot in comparison to how we were doing before implementing that type of strategies. We can always improve because there are challenges such as staff turnaround on both sides. So people who goes and comes back, you need to socialize the area with the new guy, but that's constant in our health system. About the poor people not insured and migrants, the Cali Health Secretary, that is the case that I'm the most familiar with. They have a service for citizens response, and through that service, they have a series of strategies where they provide the response from the financial point of view to those populations, but in particular what they are doing now, thinking in terms of sustainability, is the connection of that population to the subsidized system. So we do calls, open calls, so that population that is not insured can get insured in the subsidized regime. Of course, there will be cases such as the foreigners, but that is managed case to case. So they might have that team, and then it's come to the IPS, they do it. So yeah, I have to say the people who are in as irregular migrants, they are vulnerable, and that makes us when they do the consultation is not so early in the case of cancer. That's a reality.
Gracias, buenas
Thank you.
tardes.
Good afternoon.
Bueno, primero que todo, muchas gracias.
Well, first, thank you very much, doctor. I have been working with patient navigation since 2017, 2018. And I also got the international certificate of navigation. And in my experience, now that you were talking, I have had some situations that have made me like, face the reality of the health system a little bit. So now we were talking that colonoscopy, for example, that the colonoscopy is not denied. When we designed a model, I come from the coffee growing region, and I worked in an IPS, large IPS, in an quite ambitious agreement to improve the opportunity of treatment start and all the opportunities. Back then, nobody knew what patient navigation was. We are barely talking about that, and we found that the first level doctors could not order colonoscopies. They didn't have like the authority to order colonoscopy. They were not authorized if it was a first level doctor, the one ordering that. That was one of the first barriers that we faced, that we found. So we said, probably we are not going to change the reality of the insurer because the insurer has that policy and that's for the entire country. So we try that, no? Because but they say they cannot do it then because the phrase that they use it is that they cannot like leave that door open for, so they don't understand like the future that a benefit has. So in that moment, what we did is, okay, all the patient that has a suspect, well, refer to me, and we at the third level, we will do it. And only with that action, we started to diagnose a lot of cancer. We are talking about everything, not only colonoscopy. But we started to have larger advocacy in cancer. But then our second problem came, and is that we were told, yeah, but our approach was that we wanted to treat cancer in a timely fashion, but now you're diagnosing a lot. Yes, of course. So we are doing it right because that was the point. Yeah, of course, if you are looking for something, you will find it. But we were finding every time earlier diagnosis, and it's what we wanted to do. So about those analysis of the data that we were talking about now, about the recommended indicators, I see that right now there is like this trend to talk just about opportunity of starting the treatment, but also in experiences found, I have seen that everybody focuses on the treatment, but patients are not taken care of in the complementary treatment. So now everybody, now I'm working somewhere else with another insurer, and The answer that we got over there was the indicator that is the most important is the treatment onset, but you should count the stagification, stage. That should be the priority indicator. No, the treatment onset, that's the one that we're going to measure. But then that doesn't happen only with that insurer. It happens with all of them, because then the approach now it's okay. You diagnose it fast and check quick treatment, check. But what happens with the one that is diagnosed in late or advanced stages? What happens with the patients that is not giving continuity to the treatment? So the first chemo, but the second, the third one, and it didn't get it, or was not operating on, or we don't have, that we lost the windows and the clinical records, the patient outside. The window, we cannot do chemotherapy. You cannot operate. I don't know if within the indicators that you have over there to analyze cost effectiveness in the navigation programs, also it is advisable to measure this of survival, for example, or this one of the complementary timely treatment, or the diagnosis in early stages, and how much is the time that we could give to a navigation program to tell somebody this is going to be effective, because also sometimes you think that a navigation program is going to show results in year one. And my experience, I think that the results that we could not see in the program that we implemented was like 5 years later, after having implemented the navigation program. So a lot of time later, so it was not, but year one.
Esto implica entrenar personas, entrenar al primer nivel, entrenar a los médicos, que eso no es tan fácil. Entonces, más o menos, ¿en cuánto tiempo está proyectado que esos programas en serio puedan mostrar
That these programs can prove their effectiveness, and what other indicators we could include? I will try to answer in a very punctual fashion, because these could be a much broader topic. I understand the feeling when we start with the organization Partner for Cancer. We started in the year 2012, and our first harvest of results was up until 2019. That was when we first got something. It's a long work, but if the organization, I propose you early detection, thinking that we will not have an impact. This will be modest results. This will be like low fruit that we will be able to take from the tree, and we will be able to portray results that will allow us to be sustainable. Navigation needs to be sustainable. We need to pay for all the expenses, for the staff, computers. We need to have key indicators that will allow us to portray initial results. On the other hand, you were asking about if we have more indicators regarding cost effectiveness, and they are required. We need to focus in the first that will allow us to drive me from lower complexity to a higher complexity. And I'd like to add something up that we barely treat. When a chemo session is delayed 15 days, we need to readjust a formula. Here in Colombia, we are not doing it, or at least we are not measuring it to contemplate the margin of error. So these are facts that will have an impact in the livelihood and the survival of the patient. We need to measure more. What was the first question? I don't remember your first question that well, but we could discuss this, because I believe that we have an agenda that needs to move on. Thank you very much to everyone.
Muchas gracias, doctor
Thanks very
Andrés.
much, Dr. Andrés. And to wrap it up, we will have the discussion take place, patient navigation model in Colombia. We invite Sara Ramos from the CES University, Medellin. Doctor, please. Welcome.
Hola.
Hello. I'm not that tall. I can't reach the mic. Sorry. Yes.
Buenas tardes.
Good
Mi
afternoon.
nombre es Lara
My name is
Ramos.
Sara
Soy
Ramos.
docente de la Facultad de
I am a
Enfermería de la
teacher
Universidad
of
CES.
the nursery
Desde
faculty of
Medellín
CES
vengo a
University in Medellin, and
presentarles
I come here
algunas
to present
experiencias de
some
navegación que hemos
navigation experiences
realizado
that
a
we've
partir de
performed, that
proyectos de
we've had
investigación.
from in research
Les voy a
projects.
presentar en
I will
especial la
present
experiencia que hemos tenido
the
de
experience that
navegación de
we
pacientes que
have
se inyectan
with
drogas. Se ha hecho una
people
navegación
that
para
use
VIH y
drugs
hepatitis C.
for
Pues,
HIV and
hemos
C
hablado mucho de
hepatitis.
oncología, pero pues
We've
también quiero
talked a
contarles
lot
otra
oncology, but I'd
experiencia
like to portray, to bring
diferente
you
y
a
que ha
different
sido muy
experience that
reconocida a
has
nivel
been
nacional.
well acknowledged on a national level.
Bueno, ¿de dónde surgen los
Where
proyectos?
do the projects come from? The first project was a navigation project for metastasis in breast cancer. It was financed by Pfizer grants, the ASCO Foundation, and Conquer Cancer Foundation. We believed on a self-reliance and support for breast cancer and metastasis in Medellin, Colombia for females. We presented then to a call of Gilead Science, and the project was financed on a model of accessible attention to involve drug consumers, preventing HIV in Armenia, Colombia. Also, together with this Gilead project, we obtained funding through an agreement of cooperation with the Colombian Pathological Association, with resources of Gilead Colombia. We also have a project and a pilot strategy of hepatitis C detection, navigation, and linking this with the treatment for the infection by the hepatitis C virus with drug users. What have we done? I'm going to move a little bit fast because I don't have much time. We work with an interdisciplinary team. We've always done it like this, from hand in hand with a trained navigator nurse, assistant nurses, psychologists, nutritionists, social workers, peer navigators. This has been the success of our strategy for HIV and hepatitis, with a manager of the system in the health sector and health administrators, which in this case is myself. Navigation involves several elements. The navigation that we proposed in these research and projects: the education for health, for social work, advocacy, case management, and health coaching. I'm sorry. I'm like over skipping. We support in health coaching because we believe that it has an element that shares with navigation. What are these elements that they share? I don't believe it. If would it be possible for me to have another mic? Okay. So we have that both are models that are centered in the person. They are collaborative, oriented to goals, motivational. They have education and accompaniment to the patient. They are based in strengths, which means that we want to have independence in whatever illness the patient and how they deal with it. It's transformational, confidential, and respectful. We include part of these strategies in this model. What are the phases or stages that we propose? One first stage is need identification, necessity identification. We do this through the design of surveys or forms or questionnaires that have a database that allow us, after doing a questionnaire of 1 hour, or 1 hour and a half to each participant. We have a well-trained navigator that performs this questionnaire, and we identify several necessities according to the scale that we use. We try to use validated scales to get information that is trustworthy. And what we do is to identify reality and purpose as a second stage. So according to these necessities that the patient has in the face of navigation, what are their purposes and their realities. And then we go to actions. We establish for each single patient a care plan that is adapted to their own personal needs and context. We are speaking about drug users that use needles. They may be homeless if they want to quit, if they want to keep using how we do harm reduction. Then we do the proper follow-up, and we do this with our interprofessional team. We do also pedagogy, adherence as a support process, and access to appointments and medicines. And then we also run the assessment evaluation. We evaluate the compliance of goals, how that patient is behaving in the face of that navigation. And we are clear enough that we should do this with an information system that is well structured, that we know what we are to measure for us, that when we do an evaluation, that we have evidence. How we do this. And before starting, let's say, how could we prepare this? First, we should do an analysis of the context of the population, and we should map the services. Key, the networks, what health institutions we have available, and how can we optimize the communication with these entities. Then after navigation, they were speaking about this, protocols and guidelines. We need to set these navigation protocols. Then we need to train our team in navigation. Those that will be navigators need to be trained. Then we set everything up, which means we deliver a training session for the whole team to know the life condition, the context of our patients. Then we plan the evaluation, which means what we are to mean. We have a battery of indicators that are clear. We have outcomes that will be measured. We will also be measuring in the beginning, in the middle, and at the end of the process. We have a system of information and monitoring that will allow us to do this evaluation from a flexible point of view, which means that since we have this in the road there, things may happen, so we need to be flexible. We also need to join the different sectors. We need to incorporate different sectors in the table and in the discussion, and somehow politically that we may be able to adopt different strategies. I'm going to speak about the evidence of the effectiveness of navigation. We did this study. The name was chosen by those who use drugs. They gave us the name. We did a quasi-experiment research before and after with a group of 150 people in Armenia that used drugs with needles. And this was the study sponsored by Gilead. And we identified three models, three big strategies, main strategies. Accessible care attention, which is given under stigma and discrimination for those who use drugs. Co-location, which means that I have several services that are delivered together on a center, for example, of low impact center, and navigation that include linking the treatment of HIV, hepatitis, deriving to services, social services and health, with health of the attention, and accompanied to peers and education. So these people were followed for a 12-month period, and those that were detected with HIV or hepatitis C, we tried to take them to the attention and the retention of the attention. We had the battery of indicators. We wanted to improve our knowledge of HIV, reduce risky self-informed conducts, either sexual or not, success in the treatment of HIV, success in other infections, measure advocacy, and also social support and well-being. These are our main indicators of success of the program regarding co-location and navigation. We have the access health services, we measure these access. I forgot to tell you about this, but in the first month, 6 and 12 months, we see how the access of drug users raises from 45% to 95%. We measure the adherence to the treatment, and we see that adherence raises from 46 to 72.7%. The knowledge of the illness of the disease raised from 44% to 81% with this project. Then we measured the success in the treatment of HIV. We had a baseline of 45.5 indetectables, and then we raised this to 72%. And the strategy was based that the peer operator and the psychosocial professional and the nurse were doing a permanent accompaniment of the patients. We had a goal of 0 HIV cases for that year. We had one case with an incidence of 0.7%, but if we compare ourselves on a worldwide level, we see that the incidence of drug users with needles is 1.7, which means that the velocity of the infection is decreasing, and we could say that all these strategies can improve indeed and even be scaled to other cities. And psychological well-being had also positive effects. It went from 62.2 to 68.4. This was significant on the social part. They didn't experience but in everything that has to do with the self-concept improved a great deal. What time do I have left? Everything linked with the hepatitis C virus. We had extra resources with the Colombian authorities, and this is the waterfall. This is what we did to 205 people. Out of these, 172 had positive antibodies, which were pretty much 87%. Then with a diagnosis of hepatitis C, at the moment of the viral charge, we had 112, and out of those 112, we had money to link with the detection and navigation to 50 of them, and those that showed interest. Out of these, listen, we started with 50. 50 visited an expert in hepatitis, then we lost 5, 45 went straight to formulation, then 41 started the treatment, 41 the follow-up visit after 3 months, 41 are in compliance with the treatment, 37 finalized, and 37, 74% has a sustainable managed viral response. This means that if I have a strategy of navigation with a peer operator, with an assistant nurse, and managing that the homeless, half of these people were homeless population, that they may adhere, let's say that it's a work that requires intersectorial focus. And how we did it, we seated the local authorities, national authorities, health secretary, narcotics, and we said, okay, listen, if we want this population to improve their health, let's take them all the way to through the treatment. And how we did this also with giving them the medicines, and we would look for them outside of our precincts. Those that showed interest, we gave them a snack, we gave them the medication, and we have cured homeless inhabitants. 60% of these counted that it was extremely useful to use the navigator. And to wrap it up, because I don't have much time, this is the resolution of October 14, 2025, where integral policies are used for prevention, reduction, and harm reduction, and the harms in the consumption of psychoactive substances. With this project, we have done in reality measurable political advocacy, and we managed in the end to include navigation, patient navigation within the law and the strategy of people that use substances. We proved with facts that this is required for such a vulnerable population to have these programs in place.
Muchas gracias.
Thank you
doctora
very
Sara.
much. And Dr.
Muy
Sarah,
interesante su conferencia.
your conference was
Nos
very interesting.
acompaña en conexión remota
Remotely
la
with
la
us,
enfermera
we have
Vivian
Vivian
Piedradita, de
Piedradita,
la
a
Fundación
nurse
Poema, y
of
también es docente de la
Poema
Universidad del
Foundation.
Valle.
She's also a teacher
Bienvenida,
in
Vivian.
University of El Valle in Cali.
Hola, buenas noches.
Welcome.
¿Cómo están?
Welcome.
Adelante, muchas gracias.
Bueno,
Good evening. Thanks so much.
eh,
Okay.
la presentación.
The
Por favor.
presentation, please.
Bueno, buenas noches para todos. Muchas gracias por la
Good
invitación.
afternoon
Yo
to
voy a
everyone.
hacer un
Thanks
breve
for
recuento
the
de los
invitation. I
modelos de
will
navegación que hay
briefly
para Colombia.
go
Esto lo hice a
through
través,
the
pues,
navigation
de una
models in
revisión y
Colombia. I did
parte
this
de la
through
experiencia que
revision
tengo
and
en
part of the
esta
experience
parte
that I have
de
in
trabajo pues con la
these
navegación.
work
Entonces,
with
pues
navigation
ya
in
me dijeron mi
Colombia.
nombre, soy Vivian.
So you already know my name.
Llevo
I'm
unos añitos
Vivian.
trabajando
I've
esto.
been
Por favor, siguiente.
working this for a few years back. Please, next slide.
Entonces, la navegación integral, como
So
todos sabemos, pues incluye
integral
desde el
navigation
diagnóstico,
includes
de la prevención,
the
inclusive
prevention,
todo lo que han
even
hablado en el Congreso. Yo creo que
everything
no
that
tengo que
was
repetir.
said
Es
through the
transversal
Congress.
en
I
todo el
don't need to
proceso de
repeat. This is
cuidado, desde la
transversal. The
prevención, la
whole
detección
process,
temprana, el
prevention,
aprendizaje,
early
el
detection,
diagnóstico,
screening,
inclusive
diagnosis,
el
and
cuidado
more
paliativo entendido
so
no como eje
the
transversal de
palliative
atención, sino
care,
final de vida,
understood not
y aún más
only
allá en la
as the end of life,
supervivencia.
but
Digamos que en esa parte
even
estos
through
modelos pues,
survival.
no son tan claros
Part of
porque
these
todavía
models
no
are
los
not so
conocemos
clear,
muy
and in
bien.
Colombia,
De hecho, ni
we
siquiera hacemos
don't
muy
know
buen
them that
seguimiento al
well,
superviviente,
and we don't
pero
do the
también
proper
puede
follow-up to the
empezar
survivors,
en
but
esta
we can
parte
start
a
also
impactar.
focusing to have an
El
impact in
objetivo pues,
this
es reducir la
part. The
morbimortalidad y
objective is to
cáncer a través de
reduce
la
the
eliminación de barreras
mortality
para
through
atención oportuna de cáncer.
elimination
Siguiente, por
of
favor.
barrier opportunity before cancer
Entonces, pues
detection.
este modelo
So
nos
this
muestra cómo
model
pues,
shows
es
us
transversal a toda la parte
how this
del
is
tratamiento,
transversal
inclusive el final de
to
vida, y además
everything,
una cosa
even
importante
in the
que
end
se incluye en los
of the
modelos de
life, and it's
navegación
something
es
that
lo
is
que
very
tiene que ver
important that
con
it's included
la
in the
parte
models of navigation,
psicosocial y
which
el
has to
cuidado
do with the
paliativo.
psychosocial part and
Yo
palliative
les
care.
hablo de navegación desde
I'm speaking
enfermería
about
porque soy
navigation
enfermera,
from
digamos que ha sido
the
como lo que más he
nurse
estudiado y en
standpoint
la
because I'm a
literatura la
nurse
parte es
and
de
this
enfermería,
is
pero
my
el
field and the one
cuidado
I've studied.
psicosocial
But
no es
the
necesariamente que la
psychosocial
enfermera lo brinda,
care
sino que
is not
también hace todo
necessarily so
este
delivered by
engranaje
a
corporativo
nurse,
psicosocial
but
para
it
dar
goes hand in hand
seguimiento al
with
paciente.
all
Siguiente.
the psychosocial aspects to accompany the patients.
Los modelos de navegación. Ay, ¿por qué no se ve?
Navigation models.
Bueno, no sé qué pasaría allí,
I
pero
don't know
digamos los
what
modelos de
happens.
navegación
Let's say that the
se
models of
hacen
navigation
generalmente
are
por
generally
diferentes, hay que
done,
fijarse muy
applied.
bien o
You need
exactamente
to
qué
watch out
puntos específicos se
what
quieren tener en
specific
cuenta
points need to be
y
taken
estos
into
modelos de
account.
navegación
These
se hacen de
navigation points
acuerdo a las
are
necesidades
done
específicas que
according
tenga
to
el
specific
paciente o
needs
la
and requirements
institución que
of
está
the
haciendo la
institution or the
navegación. Entonces
patients
se puede
may
hacer por
have
fases, por
through the
ejemplo,
navigation. This can
por
be
la
done
fase de
in
incidencia.
different
Ahorita
stages. For
Anita
example,
lo
the
decía en
advocacy
una de las preguntas que hizo
stage.
Andrés, y es que nos hemos
Anna
dedicado mucho a hacer la
spoke about
incidencia
this,
porque
that
es lo que nos
we
miden.
focused a
Entonces,
great deal in
hacer la
advocacy
navegación en la
because it's the
incidencia es
way we are
específicamente lo
measured.
que necesitamos
So
cubrir para
this is
cumplir
what
los
we
30
need
días
to
o hasta
cover
los 44
to fulfill
de
with
inicio
the
de
30
tratamiento,
days or
pero la
44 days
continuidad la
after
dejamos,
the
la
start
dejamos un
of
poquito
the treatment. But
en
the
el lado, es
continuity,
que igual el
it's
volumen de
been left
navegación es muy
behind because the
complejo,
volume in
pero esa
adults is
continuidad es
very
súper
complex.
importante
But this
porque si
continuity
no
is
hay
very
continuidad
important
se
because
pierde la
if there is no
efectividad de la terapia y
continuity, we
generalmente
will
pues
be
los
less
pacientes están
effective in the
expuestos a
therapy and we will
complicaciones.
have
Se puede hacer
adverse
también,
clinical
de
results.
hecho, un modelo muy
And so we
interesante
can apply a
estaba
very
haciendo en
interesting
Brasil,
model that it's been
es
implemented in
aplicar una escala
Brazil,
de
which is
necesidades
apply
para el
a
paciente
necessities
y
scale
puede
or need
establecer unos grupos
scale
de
to
riesgo que
establish
permitan hacer esa navegación.
risk
Andrés
groups that
también lo decía
allow
ahora en
us
su
to
conferencia, y es
apply
que
these navigation.
desde
Andres spoke about
navegación
this, that
queremos acapararlo todo
from
y queremos cubrir
navigation,
todos los
we
pacientes y
want
terminamos es
to
apagando incendios
cover
y no haciendo
everything,
un proceso
and we
sistemático
end up
de
acting
navegación del
as
paciente. Entonces,
firefighters
esa
rather than
parte también es
systematic
importante establecer
fighters. And
cuáles
this
son
is
los
an
grupos de
important part to
riesgo.
establish
Aquí, por
what
ejemplo,
are
tenemos navegación por
the risk groups.
estudiador,
We have
tenemos
navigation
navegación
by
por patologías,
assurance, by
por grupos
pathology,
soportes, eso dependiendo
by
del tipo
groups or cohorts.
de
So it
perfil
depends
epidemiológico que tenga la
on
institución. Siguiente, por favor.
the profile the institution has.
Esto es un trabajo
This
que hemos hecho en la
is a
Fundación
work that
Poema
we've done in Poema
de los
Foundation
criterios para un
about the
programa de navegación
criteria
en una
for
IPS.
a
Esto
navigation
es,
program in an IPS, which
digamos,
is a local health provider in Colombia.
un framework, un
This
marco
is a framework or a reference frame to see what specific points we should have in whatever you want to do regarding navigation. So this is a job that we've done, Navikia, which is a navigation model that we are developing to implement navigation in child cancer. We've managed to establish these specific points on what we are to have in human talent in the cycle of attention, the coordination of the attention, the roots of authorization, in the articulation with third parties, in the strategies with information and communication, articulation with the insurance, because we work here with insurance companies, and the information systems. A very important part is that there should be well-structured databases and indicators of administrative and clinical results. We also need to focus on cost-effective measures, but we need to measure how we are measuring that management and how impactful we are. We can also measure the clinical results, managing the attention and the care and the authorization. These are punctual things that one needs to take into account to have a good established navigation program. This is as a matter of fact, that there is a poster. This model is posted there by one of the co-authors. These integrates the literature that we did in the University of Valle in the oncological nurse specialty with some students, Marcela, Juliet, and Lady, where we proposed a model with based in a revision of the literature, where we pointed specific points the model should have. How are these models being evolved elsewhere international? So this was a model published in the Salud Bosque magazine in the year 2024. And the entries that we see at the beginning, let's say, are the administrative barriers, because navigation identifies and has an impact in these barriers to allow a navigation throughout the system. And we found what limited resources had the fragmentation of the system that Andres explained, high costs for the system, and this drives us to intervene to find an exit. So we have the characterization of the network of support, the follow-up, and the individualized intervention of the navigation in each specific point, in the confirmation, in the identification, in the support plan, in the treatment, oncological support, self-care, humanitarian support, etc. What basis should we have would be the qualified human resource in the navigator sources, or whatever person is doing the navigation, the route of authorization, monitoring of analysis and returns and results indicators, because what we cannot measure, we cannot improve. And this will take us to better results and indicators in risk assessment, opportunities in the diagnosis and treatment, diminish hospitalization, which means less costs for the system, better evidence, better results, better satisfaction, less stress, and more and better administration of resources. And this is a model that is called Navigia. This is a guide of Poem Foundation, financed by Kira Grace Foundation. And what we look with Navigia is to establish navigation programs in different regions of the country, specifically for child cancer. Let's say that the main engine or the main point here is the navigation team, that it has a relation with a multidisciplinary team, the oncology pediatric teams that need support to give a priority for these pediatric patients. This has a virtuous circle with the assurance, with the routes of authorizations, but also with external service vendors and suppliers. We take the coordination of the attention. We have constant with outside teams reaching to those places that we couldn't get otherwise. We have additional relationship with the government, but also with NGOs such as cancer foundations that work for the childhood. And so you are seeing here in this side, your right side, that there is a revision of clinical orders. This is very important to avoid the patient to take further things from the patient. And so I'm sorry if you're not from here. In Colombia, we have clinical orders and authorization to access to treatments. And so let's say this should be very well done and clear for the insurance company to authorize whatever the patient may require. Next.
Entonces, aquí
And
les voy a
so
escribir rápidamente las
I'm
fases del
going to
programa
describe
de
briefly
navegación
the phases of the
de
navigation
Navigia.
program of Navigia.
Inicialmente nosotros hicimos una
Initially,
exploración
we did
pre-implementation para llevar a cabo la
previous
implementación del modelo.
exploration,
Se asignó un
previous
líder
to
de programa y
implementation.
establecimiento de
We assigned a
políticas
leader to the
instituciones
program
participantes. Se
with
hizo un diagnóstico
the institutions
estructural
that
de
were
IPS
taking
en
part. We did
segmentación, no
an
solo de IPS,
institutional
para
diagnosis
caracterizar los
of
servicios, pero
entities
también la
to
población,
characterize the
así definir
services,
el
but
mejor
also the
modelo.
population and define
La
the
selección del
more
personal de
ideal
navegación, el
model.
perfil de cargos
The
y
selection
certificaciones de
of
navegadores
the
para mirar qué
staff,
persona iba a
the
hacer ese papel.
profile of
Posteriormente se
the
hizo un
staff to see
entrenamiento,
who
allí
would
se
do
validó
what
un
job,
currículum
and then
de navegación en
training.
cáncer infantil y se
We
certificó unos
did this,
navegadores.
we certified navigators.
Posteriormente se hizo un diseño de
Then
rutas
we
y
did a
documentación
design of route and
y se
institutional
adaptó y se
documentation,
implementaron
and
esas
we
rutas
adapted
en
and implemented
instituciones que
these
están
routes
adaptadas a lo
in
que
the
ya
institution,
funciona.
adapted
Todos
to
los equipos
what
de control
is
clínico
already working,
administrativo que
all
tiene el
the
paciente, pero
clinical
además donde interviene
focus
esa
points that
navegación
we
desde
have
Navigia.
and
Se
contact
elaboró
points
una base de
through
datos
Navigia.
y aquí
We
una cosa muy
set
importante
a
se dio al
database, and
principio.
this is very
La
important.
persona que estaba antes que
This
yo
happened in the beginning.
dijo
The
algo
person
muy
that was working
importante y es que
before, that was speaking before me,
tenemos la
said
costumbre
something
de
very
hacerlo al
important, that
derecho.
we have the
Cogemos una
custom
base
of
de datos y
doing
nos metemos un montón de
things
variables que nos
the other
importan
way
y luego miramos
around.
qué medimos.
We
Así es la
want
idea.
to feed
Pero
data and see
generamos un
what
poco
comes out,
de variables
but
que toman
then
mucho
we
tiempo operativamente
get
y
many
logístico, tenemos aquí
variables
empanadas.
that
Entonces,
take
aquí
a
uno tiene
great
que
deal of
hacer
time
es
from us. So
establecer
what
qué va a
we need to
medir
do is to
para
establish
poder mirar
what
qué
to
variable
measure,
necesita
to
para
see
dar
what variable
respuesta
you
a
need
esas,
to
a esos
answer
indicadores que va a medir.
those
Entonces hicimos
indicators
una base de
that you
datos
are to measure. So
institucional
we
estructurada
set
pensando en la
these
navegación del paciente,
structured
entonces que mida
database
retrasos, que mida
thinking about
adherencia,
the
que mida
needs
gestión
of the
clínica, que
patient
mida
that
gestión
measures
administrativa, que
delays,
mida
adherence,
resultados clínicos,
administrative
que
management,
mida
but
tiempos,
also clinical
oportunidad
results,
y no solamente
times,
cuánto me estoy demorando,
opportunities,
sino cuánto
and not how much I'm
de la
taking,
proporción
how
de
long I'm
pacientes está
taking,
cumpliendo esa meta
according the
y se
what
hizo fichas
number of
técnicas
patients
basado en
are
los
fulfilling
objetivos
with this.
institucionales.
And
Esto
we
ha ido
also applied
evolucionando.
institutional
Este
indicators
año ha
that have
evolucionado
been
muchísimo. Empezamos
evolving a great deal in this
con un
year.
drive, luego con un formulario, luego con
With
una
a Drive,
con un
then with a
script,
form, then with an app,
de Google,
then with a
luego
Google
con un
script,
aplicativo,
then
bueno,
with
vamos en un
an
aplicativo web
app. So we're
súper
in a web app,
interesante
very
para esa gestión
interesting
del paciente
for the
y unos
patient
indicadores en
management,
lo que es en Power
and
BI
some
que
indicators in
hacen
Power
un
BI
tablero de gestión
that make immediate
automática con base en
management
los datos que
word
generamos
based on the data that we feel
en la base de datos.
in the
Siguiente.
database.
Y por último, pues la idea es implementar el programa con
And
todas estas
finally, the
cosas que
idea
hemos
is to
hecho,
implement the program with
implementar
everything
ese
that we have
sistema de
done,
información, hacer
implementing
la
that
recolección de
information
información,
system,
realizar acompañamiento y supervisión y
gathering the
entrenamiento en esa
information,
base de
providing
datos para
support,
tener un
training
mejoramiento
those
continuo de la
databases
calidad. Y por último, con la medición de los
for continued
indicadores, ver
quality
los
improvement.
resultados
And
de la
finally, with
implementación.
the
Ana lo
indicators,
decía, Anita lo
check
decía
the
hace un rato,
implementation. It was said,
uno no tiene resultados de la noche a la
you
mañana.
don't have
Los
results
programas de navegación
overnight.
son algo de
The
largo aliento.
navigation
Estos pasos
programs
de
is
largo
something
aliento no
long
van a
term
resultar, van a
that
impactar
are
muy
not gonna,
rápidamente,
well,
sí,
they will have a
porque
quick
sí,
impact,
claramente
yes,
impactan, pero para
elements,
medir
because,
resultados,
but to
eso toma
measure
un tiempo.
results, that takes a
Siguiente.
while.
Y este es otro
And
modelo, por ejemplo,
this is
de rol de
another
navegación en los hayas,
model of the
con
role
los
of
adultos jóvenes,
navigation in
adolescentes y adultos
the
jóvenes,
adolescent and young
que se
adults
propuso en un congreso que
that
hicimos ahorita,
were
donde el
proposing a
paciente
congress
pediátrico tiene esa
where the
transición a la
pediatric
oncología de
patient has
adultos
that
y donde
transition to
navegación puede
adult oncology, and
acompañarlo
where
realizando la
navigation
coordinación de los
can
cuidados,
support with the
educación y
coordination of
empoderamiento,
care, education,
defensoría del
empowerment,
paciente y evaluación de
defending
resultados,
patients,
para que ese
and
paciente no quede como
results
tan solito
assessments,
y
so
quede
that that
volando en el
patient is
sistema,
not
sino
left
que haya
so
esa
alone
transición
and they are like a
coordinada
fly
y
in the system
acompañamiento
or
para que
loose,
el paciente
but there
tenga
is
mejores
coordinated
resultados.
support so
Siguiente.
that the patient can have better results. Next.
Desafíos en la transición, hay muchos,
Challenges
no sé
in
por qué le está
the
saliendo una cara
transition.
positiva.
There are many. I don't know why we
Primero, a
cannot
veces
see
no es
the slide
fácil
very
la
well. First,
transición porque el
it's
paciente
not
está
easy
muy
the
acostumbrado
transition
a ser un paciente
because the
pediátrico
patient
donde
is
sus
quite
papás
used to
tienen
be
que
a
hacer
pediatric
todo y
patient where the
estos niños
parents
pues
have
ya
to
se
do
vuelven
everything.
adultos y la idea es
And
que
these kids
hagan
have
esa
become
transición y se
adults, and the idea
empoderen
is
y
for
se
them to
vuelvan como
have that
adultos
transition
jóvenes
and
sin
empower
perder
themselves as the young
esa
adults,
autogestión
and for
de
them
sus
to do that
necesidades.
self-management of their
A veces no hay
needs.
comunicación entre los equipos de
Sometimes
adultos y
there's no
pediátricos, eso es
communication between the pediatrics and adults team. That's an important challenge. The complication sometimes there is not a follow-up in the long term, and authorizations, for example, if there is not a follow-up and articulation, it's hard for the kids.
Y este es el modelo de navegación propuesto
And
para
this
estos
is the
áreas.
navigation
La
model
evaluación inicial
proposed
tiene
for
14
those
a 17 años.
AYS.
Identificar barreras,
Identify
luego crear un plan
barriers and
individualizado de
then create an
transición,
individual
planificar
transition
6 a 12
profile,
meses antes el desarrollo
planning
de
6
este
to
plan de
12 months
transición y
before the
coordinarlo
carry
con
out
los
of that
servicios de
transition
adultos,
plan and coordinating with the
preparar
adult services,
intensivamente 3 a 6 meses antes
prepare
el entrenamiento de habilidades de
intensively
autocuidado y
the
desarrollo
training
de
of
autonomía
self-care
luego de que el
skills
paciente empiece a
and
hacer ya
development gradual autonomy
la
so
transición
that the
activa,
patient does
acompañamiento directo en la
things, the
primera
active
consulta. Esto para
transition,
nosotros es
directed
muy
support
difícil
in the
porque
first
por los volúmenes
consultation.
que manejamos, aunque
That is
digamos que
quite hard
pues no
for
son
us
tantos
because
porque
the
son
volumes that
pediátricos,
we manage, well,
facilitación de
it's not so many
comunicación
because
y
it's
prevención y
pediatrics,
el
facilitation of
seguimiento
the
con
communication,
monitoreo
and
sistemático de
the
adaptación e
follow-up with
intervención en de
systematic
apoyo y
adaptation and
necesidades,
follow-up
además de
support
evaluación de
interventions and
resultados
need,
y
in addition
satisfacción
to
del
result
cliente.
assessment and satisfaction.
Los indicadores de éxito pues pueden ser
The
muchos, puede ser
success
la satisfacción del
indicators can be
paciente, puede
many. It
ser
can be patient
cuántos
satisfaction.
pacientes están
It can
haciendo
be
efectivamente esa
how many
transición, cuántos
patients are
pacientes son presentados o
indeed
llevados
having that
conjuntamente en
transition, how
una
many
consulta,
patients
cuántos
are
pacientes
managed in the board,
pueden hacerse
how
seguimiento de
many
complicaciones
patients,
a largo
because
plazo
we
o
can do
evitar esas
follow-up
complicaciones a
complications in the
largo
long
plazo.
term or
Siguiente.
avoid those complications in the long term.
Y pues para cerrar esto,
And to
ningún
close
paciente o
this,
nadie debería
no patient or
tener que morir
nobody
simplemente por ser pobre.
would have to die
Como
for being
frase
poor.
de Harold Freeman.
You know,
Con esto
no one
termino.
should
Muchas
die
gracias.
simply because they're poor. Yeah. By Dr. Harold Freeman.
Muchas gracias.
And I close
Bibi.
with this. Thank you very much, Bibi.
Invitamos al doctor
We
Belmont.
invite now Dr. Belmont.
La doctora Alejandra Taborda,
Dr. Alejandra
desde la
Taborda
Secretaría de Salud de
from
Bogotá,
the Bogota
nos va a
Health
hablar de un tema
Secretary is going to
interesante
talk
en
about
relación al modelo
something interesting
que
about
están
the
implementando
relationship that the model
ellos.
that they are implementing over here.
Muy buenas tardes.
Good afternoon.
En nombre del señor
On
secretario
behalf
Gerson
of
Vermont,
the Secretary Gerson
les
Vermont,
transmito un saludo
I
muy especial.
sent a
Todo
special
por un motivo de
regards.
fuerza
He,
mayor no pudo
due
asistir.
to force
Estaba
majeure, he couldn't
supremamente
come.
agendado.
His
momento,
schedule was very tight,
está haciendo
and right
una
now
función
he
fundamental.
is actually doing
Voy
some
a
navigation.
empezar
So I will get
por
started by
parte del final. Voy a
part of that.
spoilear.
I will spoil.
Joana es una dura, una guerrera, una berraca, una luchadora. Joana es una persona muy alegre, muy
Joanna
positiva.
is a
que da
very happy
oportunidades y
person
se está
that
dando la
gives
oportunidad
opportunities, and it's
más
getting
grande de
is
su
giving her
vida, que
biggest
es vivir.
opportunity in her life, that it's
Ella hace
living.
parte del
She
programa
is part
Navegadores de
of
Bienestar,
the
una
program
estrategia del
Wellbeing
distrito
Navigators,
liderada por
a
la
strategy
Secretaría de Salud. Su
by the
misión,
City
acompañar a
Hall,
mujeres en
led by the
proceso de
Secretary of
diagnóstico de
Education's
cáncer de
function,
mama o de cuello
support
uterino,
women
para que
in
ninguna
the
se quede sola
diagnosis of
sin
uterus
respuestas ni
cancer
atención
or
oportuna.
breast
Hace poco recibió una
breast
noticia que
or
cambió su
uterus cancer.
rumbo,
She
pero
just
también
recently
encontró
got
una
news that
mano que la
changed his
acompaña.
path,
Soy
but she also
mamá
found a
soltera,
hand that is guiding her.
cabeza de
I am a
familia, 3
mom, a
hijos,
single,
trabajadora.
three
Las
kids,
flores
a
desde chiquita
worker.
han sido
I
lo
work
mío.
with the
A mí
flowers since I
hace
was a
2
kid. It
años
has been my thing. 2
empezaron a
years ago,
hacer ecografías de seno
I started
y
to
la
take
doctora que me atendió me dijo
breast
tienes una masa en
ultrasounds,
el
and the
seno,
doctor told me
entonces
you
vamos a
have a
empezar a
lump
hacer un
in your breast,
seguimiento
so
y
we're
así
gonna
fue.
start
Cada
with the
año me estaban
follow-up.
haciendo
And it was
ecografía. El
every
año
year I was
pasado
getting an
tuve una
ultrasound. Last
cirugía,
year I had a
el
surgery.
ginecólogo me ordenó
The
mamografía y biopsia
gynecologist
porque la
ordered
masa seguía
a
creciendo.
mammograph
La
and a
navegadora te
biopsy
acompaña en la
because
cita,
the
la
mass kept
biopsia,
growing.
la espera del
So she
resultado y el
supported in
inicio
the
del tratamiento
biopsy
oportuno.
weight of the result and the
Navegadores
start
de
of the
bienestar
timely result.
son
Well-being
ángeles,
navigators, they are
ángeles
angels. They are
acompañantes,
angels
ángeles
that support,
que
supporting
ayudan,
angels,
que sostienen,
accompanying
pero
angels,
sobre
angels
todo
that
son
support, that,
ángeles muy
well, but
humanos.
especially
Ella
they are
estaba
very
conmigo
humane
en un momento muy
angels
difícil que fue el día de la biopsia.
because she was with me in a
Yo le
very
decía,
difficult
es
moment. That was
increíble,
the
una
biopsy.
persona que
And I
nunca
told her,
había
it's
visto en
amazing.
mi vida,
Somebody
que no
who
tenemos una
I had
cercanía,
never
nos
seen in my
está
life. We
y
are not close. We
está
are not
ahí
friends. And she's
apoyando.
there for me,
Y pues obviamente
supporting
pues
me.
muy
And
bueno,
of
o sea, el
course, it's
programa de ustedes
something
sí
very
está
good. Of course,
funcionando.
your program,
Y bueno,
it's
ya
actually
hicimos la
working.
primera cita,
And well,
ya tuvimos
we
la
had
orden de
already the first
biopsia.
appointment.
Estoy
Now
afiliada
I
a
have the
Capital
order for
Salud
the
hace
biopsy.
un promedio de 15 años y
My
siempre me ha
insurance
ido muy
Capital
bien.
Salud for
Las
over
citas,
15
la
years,
atención
and
en
I have always
urgencias,
had
citas
very good
médicas,
health
medicina,
care
en general me ha ido muy bien y con este
appointments in
programa
general. It has been
excelente.
very good. And with this
más
program, it
bienestar
has been
se
good.
eliminan barreras,
With more
se acelera el
well-being,
acceso al
barriers are
sistema y se
eliminated.
ofrece un servicio robusto e integral.
And
O
we
sea,
offer
haberlo
a robust
sacado
and
adelante
comprehensive
como están
system.
sacando adelante el
Yeah, I
programa
mean,
me parece
making
excelente,
this
porque
program
van a ayudar a mucha
progress
gente
of
y con eso
go
muchas
through,
vidas y con muchas
and
vidas, muchas
with a lot of
familias.
Joana
lives and a
sueña
lot
con
of
viajar,
families.
volver a
Yes,
respirar con
Joanna
calma,
dreams
porque
with
vivir también es un
traveling
acto de
again,
valentía.
breathing
Mi
again,
nombre es Joana
because living
Fajardo, estoy
it's also
navegando por
bravery.
Capital Salud
Yeah, and
y
Joanna
navegadores
Fajardo,
de
I'm
bienestar.
navigating with Capital Salute
Capital
and
Salud
Well-Being
te
Navigators.
cuida.
Capital Salute takes care of you.
Bueno,
Well,
una muestra de lo que estamos haciendo
a sample of what we are doing with our patients
de Capital Salud
in
ha sido un
Capital
esfuerzo
Salute.
increíble.
It has
Yo,
been amazing
de
effort.
verdad,
Actually,
quiero,
I want
antes de
to,
contarles la
before telling you
experiencia,
the experience, I want to thank our team of navigators.
Veo aquí
That I
varios
see here
presentes.
some
Sin
of them.
ellos esto
Without
no es
them,
posible,
this wouldn't be
sin ellas,
possible
porque la mayoría son
because
mujeres.
most of them are women. And so we have a team structure of the team in the secretary of around 20 people.
Tenemos, ustedes
We
saben que
have,
Bogotá tiene
you
una
know that
estructura
Bogota has a
territorial en
territorial
salud
structure
por
in
subredes.
health that is
Tenemos
divided
4
in
subredes de
sub-networks.
servicios de salud
We have 4
y
sub-networks
yo
of health
lidero la
services,
subsecretaría
and
de
I
gestión
lead the
territorial,
subsecretary of territorial
participación y servicio a la
management,
ciudadanía.
participation
Y
and
créanme que
citizen
no es
services. And
fácil
believe me,
pensar
that
en
is not
cómo
easy
generar
to think about how
acciones
to
que tengan
generate
un
actions
impacto
that can have an impact,
completo
or a full,
en la ciudad,
complete impact
porque son
on
20
the city,
localidades.
because it's 20
Y ustedes
localities. And
conocen,
you
para
know,
las personas que están
for the
conectadas
people
y
who
quienes
are
no conocen a
connected,
Bogotá,
and those who
les
are not
resumo,
familiar with
Bogotá
Bogota, I summarize
tiene
Bogota has
alrededor de 8
around
millones de
8
habitantes,
million
tiene 20
people,
localidades,
inhabitants,
tiene
20
una localidad
localities,
100% rural, Sumapaz,
one district that
donde
is 100%
difícilmente
rural,
las personas
Sumapaz,
tienen
where hardly
acceso
people
directo a los
can have
servicios de
direct access
salud,
to health
y se
services.
configuran los
And,
anillos de zonas de la inequidad. Entonces
and
vemos
that's
que en
where
el
we have the
norte de
rings
la
of
ciudad
inequality.
y en
So
el
we see that in
oriente
the north
hay una
and in the
oferta
east of the city,
significativa,
there is
lo que
significant
no
offer,
ocurre
what
en el
doesn't
sur
happen
y
in
el
the south
occidente.
and the
Entonces,
east. So
lo que nosotros les
what
queremos
we
compartir, y yo
want
quiero
to share,
agradecerle
and I want to
de
thank
verdad al señor secretario
really
por
the secretary for
seguirnos la corriente, por
following along with
promover y defender
this,
una estrategia como esta.
promoting and defending
Somos
this
casi
kind of a
20
strategy. It's
personas
almost
dedicadas a la
20
navegación de
people
bienestar,
dedicated
pero
to
el
the
reto
navigation of
no
well-being,
ha sido
but
conformar
the
un equipo,
challenge
el
hasn't
reto ha
been
sido
setting up
articular
the
todos
team,
los
but it
procesos.
has been articulating all the
Nosotros,
processes.
bueno, el
We
secretario
are
le
the
llamó a esta charla
secretary
de
called
Harlem
this
a
talk
Bogotá,
from Harlem to
de
Bogota,
Harlem a las subredes,
from Harlem to the
la
sub-networks,
navegación como un instrumento de
navigation as
bienestar,
an instrument
y
of
les voy a
well-being,
contar por
and
qué.
I'm going to tell you why.
Esta
This
estrategia, este
strategy,
modelo que tenemos en
this
Bogotá,
model that we have
tiene una
in Bogota
fundamentación en la atención
has
primaria social.
its grounds on the
Nosotros
social
reconocemos
primary
en
care.
el
We
distrito
recognize in the district, at the
que,
level of the city,
bueno,
you know,
la
City Hall,
atención
that the
primaria
primary
en salud
care in health
debe transformarse y
should be
evolucionar
transformed
a
and
una
evolve
atención primaria social.
to
¿Por qué?
social
La
primary
salud
care, because
depende
health
en un
depends
11% de los
11%
servicios de salud.
on the health
¿Y el
services.
resto qué?
And what about the
El
rest?
resto, el
The rest,
89%,
the remaining
depende de
89%,
unos
depends
determinantes
or relies on some
sociales,
social,
ambientales,
environmental
comportamentales,
uh,
etc.
determinants,
Entonces,
etc. So
yo realmente
I
veo que aquí hay
actually see
personas
that
que
here
llevan
we have a
15,
people
20
that have been for
o más años
15,
navegando.
20 or more years
Yo
navigating.
realmente
Actually,
soy
I
neófita en
am
este tema
new in
y
this,
atrevida también
and
al proponer una
I
estrategia
think that
con un alcance
I am
diferente.
daring by
Nuestra
proposing
navegación se
different kind of a strategy. Our navigation
la infraestructura
leaves out
hospitalaria.
of the
Nuestra navegación
of the hospital
trasciende
infrastructure. Our
todos los
navigation
servicios de salud
goes beyond
porque
all the
estamos
health services,
navegando
because we
en
are
el bienestar.
navigating
Y eso
through
significa
well-being,
que nos
and
toca
that means
pensarnos
that
distinto,
we
que
have to think
inclusive
different
tengamos que
ourselves.
pensarnos
That even we
en
have
la
to think
comunidad,
ourselves about the
en
community,
todas esas capacidades.
in
Yo
all those capacities,
seguramente
and
con el
probably
agradecimiento
with by thanking Dr. Freeman, and it has been quite mentioned here. I think that is very interesting to think that as you can see the evolution of the stake, how it has been transformed, and definitely this is the summary of what we are doing. This is what we can do based on social primary care, and that model that we see here as some planets turning around have this particularity, and is that we put at the center the people, the families, and the communities. And we are declaring that the health cannot be improved if we are not able to approach the social determinants of health. So we have four strategic components. One, the observatory and the entire consolidation of the information systems and interoperability to be able to have a radar, a smart way to reach people. Our basic equipment, and like what is being proposed by the national government, our teams, sorry, they know what they are going to do in the territories. And it's the teams that manage the well-being. They have a presence, for example, in all the localities with some priority criteria according to social vulnerability. But part of the recognition of this model is that the task we cannot do it by ourselves. The secretary says that the main responsible for health, not for taking away responsibilities, but the main responsible for health in the city is the mayor, because it's that we need to generate cooperative work that allows us actually to exceed or overcome all those inequalities of health. So in there you can see all these elements, as I have a contact all the time with communities. I can explain this very easily. As an avatar on top is the tower of control, the information that we need to see and make decisions. To the right, we have usually when we have this pact of alliance, we agreed with our right hand, and that's intersectoriality, so that we can expand the scope and the possibilities of social primary care. At the bottom, we have the fit for action, and it's all the comprehensive service of management for health, all the layers of the health services in function and purpose. We are in Bogota trying to implement that in the low complexity. We have high technology to be able to solve in a timely fashion all the different problems. And to the left, we have all the component of transforming social reality. This is a summary model, more well-being based on social primary care. But perhaps this is the chart, because you have seen the chart of the seminal model of Freeman. And this is like the chart version. So perhaps it's the most important stake for the secretary right now. And it's a different kind of navigation. And we configure this in the socio-sanitary system. That is nothing else than trying to find that well-being. Right here, we in this structure, if I can have a mic, sorry, so that I can move.
Hola, hola. Entonces, miren, esta es la evolución.
This is the evolution of the stake that we have in the district of our objective, that what we are working for. So we are here in a piece because the navigation has a beginning and has an end, as you are already familiar with. As you know, our navigation ends with the start of treatment, but patients are not left alone. We are guaranteeing that during the entire continuum of healthy care, from the promotion and maintenance of health, we can guarantee that these groups of patients, women, families, because we are not navigating just the patients, but also the families. So, socio-sanitary navigation, what does it mean? That we have to become experts in qualitative methods And depending in all those social determinants, our team has proven we can do it. And maybe here we are integrating all the areas of this Secretary of Health. There is nobody more empowered than that person that survived cancer. There is not a community that becomes stronger after those processes of resilience based on social cohesion. So those two elements for us from the subsecretary are extremely relevant at the same time that we navigate, we educate, we hear, we listen, and we will generate this mass of capacities, critical mass of capacities, so that these patients can become expert patients. Will enable them to do that. And we don't stay there. We're working with all the social organizations of patients. Bogotá is quite particular, and Colombia has a social participation policy in health. So this means that we have formal instances, we have diverse population groups, and we have patient associations, and with all of them, we are working. I could stay here telling you all the details, but we have made progress in guidelines, in protocols, articulation, and I want to highlight this territorial component management for social primary care, because basically it's about 4 elements, 4 types of articulation. The first one is inside the secretary, basic. We have a table of interdependence, interreliance for chronic diseases, and like a kind of a child for all the oncological aspects. And there we have all the areas. We have the second articulation from the territorial management, that is the sector one, the capacity of working with all the actors. Last year, we were able to manage for all the EPSs or the HMOs, even those intervene, can sign an agreement to be part of this model. Third one, the intersector articulation. We are working hand in hand with all the social sectors, education, economic, health, culture, social integration, and as a milestone for the city, finally, we have an intersector commission for the determinants of health and well-being. The fourth one is the community, and that's strength. Because in summary, territorial management for a city like Bogota, with all the diversities, territorial management becomes that invisible threat for all the things to happen, so that the model becomes material. That's why it's so important. And as I know that we are short on time, but I will just give you this short preview, but I know it's not the time. By recognizing this navigation at the time that we accompany patients, because we have some criteria for early detection and confirmed diagnosis in those patients with high suspicion that had not started the treatment, to those women and their families. We have a strategy that is called social prescription, and it's part of the community navigation, and is that we make available all the social offer of the district. So we have been able to close barriers that are not administrative, going to the root of inequality. For example, we have those health routes that allow us to facilitate women transportation for them to attend the services, appointments, and else. And this is just, as I said, a preview, because I cannot spoil. It's just a spoiler. Because I not spent a lot of time here, you know? I mean, I was listening to you. It's been 20 years navigating, 15 years. We launched this program in May 29 this year. It has been a challenge because our approach has been targeted to the incidents, to the new cases. So the big challenge right now, our first cohort, is with the majority of the patients in the subsidized system with Capital Salud. And within the challenges that we have is escalating, not only with all the insurers or payers, but with other types of cancer. That's the challenge, according to this shock plan that we have in the country. And well, data. We found a percentage of contactability of 47%. And thanks to this work of the navigators team of maybe the community effort, we have been able to increase this is average, but we have been able to have this 90% contactability. So it means that we're generating trust in the communities, and that's very positive. We have opportunity of closing administrative barriers, 19.8 days, considering that it's still the point of the tip of the iceberg, administrative barriers, and that gives account of a fragmentation of the system. Now,
Gracias al
thanks
trabajo
to
con
the work with other sectors,
el cierre de barreras
that closure of non-administrative barriers becomes a way to materialize the social primary care. Here we have an average of this satisfaction index of the navigation. This is a scale from 1 to 5. This is an indicator that this is the path.
en esta forma
And this
integral.
comprehensive form of doing navigation. It's fascinating, everything that we have that I would like to show you, but I can tell you.
Ver estos clústeres de
Just a
pacientes
spoiler, because looking at these clusters of patients
de la ciudad es increíble porque nos estamos
all over the city,
anticipando
it's amazing because we are anticipating ourselves not only to the risks, but we know that there are problems in access. And we are not just waiting to get the PQR, the lawsuit, but we are anticipating ourselves. And you know everything that this means. So you know that our statement is that the declaration of well-being is a strategy where all of us win, everybody wins. Everybody, there is not one stakeholder that does not get benefited from that navigation. And I will tell you personally, navigation is, as Julio Frank says, in the definition of the health system, navigation would be organized social response in terms of a problem. So for me, navigation is social technology that might be molded according to the context and need. And today, let me tell you, in Colombia, we are not just navigating, we are navigating in the middle of a storm with a lot of wind. You know, tailwind, you know, those who have navigated, you know that very well. That's an additional difficulty for us.
ahora casi no llego
Now, I mean, it was very hard for me to make it here because of the rain. And I said, well, I'm going to make it. I'm going to make it because, I mean, I have the responsibility of taking the message. And, well,
simplemente dejarles los desafíos, claro. Esto
yes,
no
to
es
show you the challenges. Of course, this is not a
película rosa, todo ha sido
everything a bed
perfecto.
of roses.
No ha sido un constante
It has been
aprendizaje.
not perfect, so it has
Y
been
quizás
constant learning.
los retos más
And perhaps the
importantes son
most important
en
challenges
frente a la
are about
interoperabilidad
the interoperability
con otros sectores
with other
y en el mismo
sectors
sector,
and
por
in the
supuesto,
same sector, of course,
que podamos desplegar,
for us to be able
medir y
to
escalar la
measure,
prescripción social
scale the
comunitaria.
social
Ahí
prescription
hay
is
un
a
reto importante a
benefit.
propósito de la
That is an
costo-efectividad.
important challenge in terms of cost
Necesitamos
effectiveness.
que la
We
Comisión
need for the
Intersectorial
intersector
considere
commission to consider
todo esto que estamos
all
haciendo,
of this that
quizá
we are doing, and for this
de
to
un
be
alcance
or to have this
distrital y beneficio
scope at the
para
district level
no
in terms of
solamente
benefits,
pacientes y
not only for the
familias, sino
patients and the
padecen
families
cáncer de mama
that go through
citoxina,
this breast cancer,
todos,
but for all the others, you know,
colorectal,
stomach,
próstata,
colorectal,
son
prostate, and
prioritarios
child
en
cancer
zona
that are
para el país.
the priority ones right
Y
now
por
for the
supuesto,
country in this moment. And
creemos
of
que
course, we
por
believe
ahí estamos
and
mirando cómo lo
we
vamos
are
a
thinking
lograr
about how
con
we
las
are going to
sociedades
make it with the
científicas,
scientific
poder generar más
associations,
capacidades
being
de
able to
formación
generate more
coloquiales y
capacity and
multimodales en
training
diferentes
in
profesionales de la
oncology
salud.
for different health professionals, as well as training in navigation to all the stakeholders in this system. And I want to close by thanking the Dean of Nursing in this university. That is also my alma mater. And coming here, I felt amazing nostalgia because I hadn't been here like in 20 years.
Esta es una frase de
This
señor
is a
secretario.
phrase from the
Él nos ha dicho
secretary.
en
He
diferentes
has
espacios
told us in different
frases que nos
spaces
tocan y nos
some
conmueven.
phrases
Dice,
that touches a
una
lot.
mujer puede vivir con
But it
cáncer,
says a woman
pero
can
una
live with
mujer
cancer,
nunca
but
le
they
cáncer.
shouldn't live for
Y creo
cancer.
que eso hace parte
And I
de la
think that
encuesta
that's
y la
part of the
declaración
stake
que tenemos
and the
como más
statement that we
bienestar.
have like
Así que
better
nosotros
and
estamos
more well-being.
navegando no la
So we are
enfermedad,
navigating
sino la
not through
vida,
the disease, but
y
through
que
life. And
navegar es acompañar
navigating
con
is
humanidad
supporting
y
or
es
accompanying with a
convertir
humanity,
el cuidado
and it's
en más
turning
bienestar.
a care into
Muchas
more
gracias.
well-being. Thank you very much.
Muchas gracias, doctora.
Thank you, Dr.
Doctora Alejandra.
Alejandra.
La
So
profesora
now
Sandra
we
Pacheco,
invite Professor Sandra
quien
Pacheco,
realizará la moderación.
who will be moderating,
Las personas del
and
público,
people in the audience.
si tienen preguntas, para que por
Should you have
favor
any
las
questions,
realicen.
please.
Mientras esto sucede, les pido el favor a los
Meanwhile,
conferencistas
please, the
que nos acompañaron el día de hoy, que nos
presenters, all the
acompañen a una
speakers that were
reunión
here,
de carácter
please
prioritario
join us
en
our
el noveno
priority
piso
meeting
de
on the
este
9th
mismo
floor in this
edificio,
building
terminando la
after
sesión.
we finish the
Muchas
session,
gracias.
okay? All the speakers are expected to be on the 9th floor.
Buenas tardes.
Good afternoon.
Muchas gracias a las doctoras.
Thank you very much,
Sara,
doctors,
Vivian,
Sara,
doctora de la
Vivian,
Secretaría de Salud de Bogotá también. Dos
Nancy.
preguntitas.
Two
Yo
questions.
pertenezco al área médica, pero me interesa mucho.
I am not a
Soy
clinician,
de
but I am
cafetero
interested. I come
y
from the coffee
desafortunadamente
growing
para la
region, and
doctora
unfortunately
Sara,
for Dr. Sara,
lo que es Armenia y Pereira tiene unas
Armenia and
condiciones
Pereira have
socioeconómicas
some
después del terremoto
hard socioeconomic
que ha
conditions after the
incrementado la
earthquake
adicción a la heroína
that has
y el número
increased
de habitantes de calle.
heroin
Entonces,
addiction
la
and the number
pregunta
of homeless
es,
people.
doctora
So
Sara,
the question is, Dr.
ese
Sarah,
proyecto que duró 12
that
meses,
project that
sí
lasted for
dejó
12
las
months,
raíces suficientes
did
para
it live
que
for
la
enough
Secretaría
roots
de Armenia
for
de
the
Salud y las
Secretary of Health for
EPS
Armenia and the
continuaran el
IPSs
proyecto
to
porque
continue
sus
with the
habitantes de
project
calle
and
y
those
que cada día
homeless
se
people
incrementan más en
that
Armenia y
keep
en
growing
Pereira
every day
por
in Armenia and
son ciudades
Pereira
pequeñas
because
y
they
hay un
are
problema
small cities and there is
sociólogo de
this
hace años
social problem.
para que les atiendan el VIH
So
con verdadera
that
eficacia y la
they
hepatitis C. Eso sí
can
se ha podido
get healthcare for
continuar con
HIV
el
and
tiempo o
hepatitis
quedó
C
ahí
with
el
time.
proyecto
I mean, is it still happening
por
or?
parte de ustedes únicamente.
Bueno,
Well, yeah,
proyecto se hizo en alianza
the
con la Secretaría de
project
Salud de
was built
Armenia,
together
precisamente
in
para que tuviera
alliance with
algo
the
de
head secretary of
sostenibilidad.
Armenia, so that is
Y
sustainable.
sí,
And
hay asuntos del proyecto
yes,
que van a
there are
quedar,
things in the project
digamos, consignados
that are going to be
en esos servicios de bajo umbral que tiene
included in
Armenia.
those low threshold services that
Hay
Armenia
muchos
has.
desafíos,
In
Armenia es el
spite of
único
the fact that there are
país
many
que
challenges,
tiene
Armenia
un
is the only
servicio de
city
bajo
in the country
umbral que
that has a
está
low threshold
todo el año
service that
funcionando
is
y
working
que
all
funciona
year
con
round
fondos del PIB.
and that works with these resources
Entonces,
from
a partir
PIC.
de este
So
proyecto
based on
que
this
yo les conté que
project
había
that I
tenido una
told
incidencia
you, that we
política al
have
There were
respecto,
several actions in
nosotros como
political
universidad
advocacy.
estamos en
Us,
ese
as a
momento
university, we are in that
desarrollando los
moment.
planes
We
de
were in that
gestión de
moment
reducción de riesgos de
developing the
daños para el
plans
eje
of harm
cafetero,
reduction
Pereira,
for
Armenia y Dos
the
Quebradas.
coffee
Y
region,
dentro de esos planes
Armenia and Dos
territoriales
Quebradas.
de
And
gestión
within these
territorial
territorial
está incluida la
plans,
navegación.
we
O
included
sea, se incluye la
navigation.
navegación, la cubicación y la cohesión
Navigation,
accesible como tres elementos
co-location,
centrales
and
que deben quedar
accessibility are
como
three
unas
key elements
apuestas
that
a
are
corto,
to be
mediano y
set
largo plazo
as
que se deben
clear
ejecutar en el
short,
territorio con
medium,
apoyo
and
pues, de los
long-term bets
ministerios.
with the support of
Y
the
a la vez
ministry.
hay
And
una
at the same
sostenibilidad a
time,
nivel
there
nacional
is
con un modelo
a
de gestión de
national
reducción de riesgos
sustainability
y
with a
daños que también
harm
incluye
reduction
la
model that
navegación.
includes also
Entonces,
navigation.
digamos que por más
And
de que
so
se
let's say
terminó el
that
proyecto, siguen
as much
amarrando
as the
entonces,
project
seguimos
is
amarrando un poco
through,
los
we are still
modelos
speaking about
en los planes
the
territoriales de
incorporation of the
reducción de
models
riesgos y
within
daños
the
y
territorial
la
plans
Secretaría
of
de
harm
Salud
reduction, and
de
the Health
Armenia
Secretary
tiene
of
toda la
Armenia
voluntad para
has
seguir con la
all the
navegación por
will
parte del ente
to keep
territorial, especialmente
going
pues
this way,
para las personas que están
especially for
buscando
those
entonces
that
que
use
sí es
drugs.
sostenible en el tiempo.
It is sustainable through the time. Thanks so much, Sarah. I also had the same question or similar. What will be the next steps to strengthen that strategy of navigation that you have in place? But I believe that you already answered to such question. I have another question for Dr. Alejandra. Doctor, how can you couple this interesting model of well-being navigators with new orientations that the ministry MOH has regarding the reforms? How do you couple them? We have several challenges within the frame of territorial needs. We evidence several aspects that may favor, but others that are negative. And in the face of these concerns, what we've managed to do is to strengthen. Let's imagine maybe a border of productive possibilities. In the y-axis, we have health. In the x-axis, we have other sectors, and you may evidence several layers. First is infrastructure. Second, maybe the basic teams outside of the facilities. Then all the management in public health and the plan of collective intervention. And then the question is, what is the main goal of that attention? And then you are left with the border, and the border is our communities. And so we have foreseen for the next 2 years to have training and formation of communitary navigators for the well-being of around 50,000 navigators in our district. This means waterfall methodology with key supporters and key foundations. We are doing these tasks that they will accompany us all through the process, but it's basically an exercise of installing capacities and managing to do it. Because despite I say that reform processes are the storm and the wind, but we cannot cease to navigate. So what is most important is that for that navigation, we should be resourcefully ready, because the ports will always be there. Our beacon, our lighthouse will be there. We need to have well-being despite the storm, because if we only complain, then we won't be able to set sail. Thanks so much, Doctor. Very interesting. Vivian, I have a question regarding the role of the navigator that you were talking about from Ajax navigation. This is a population with several particularities regarding context. You fill us in about the experience that you had in Poema Foundation. What were these identified barriers specifically for this population?
Sí, la población Ajax es una
Yes,
población muy
Ajax
compleja
population is a very
porque
complex one
no
because
son niños, pero tampoco son adultos.
they are not kids, but not
Es
adults
difícil
either.
hacer esa
So it's
transición
tough to
porque
do this
la idea es que
transition,
los pacientes
because
ojalá
the
el
idea is that the
seguimiento
patients,
continuara con
the
hematología
follow-up
pediátrica y con
would
equipos de
keep
hematología
on going with
pediátrica al menos hasta que uno
hematology
quisiera por
and
ahí hasta los
pediatric
25 años,
equipment.
pero
You
por la
would
normatividad
wish up
ya se
until
establece
25
que
years of
hasta
age,
los
but
8 años la
given
mayoría de
national
edad, pues
regulations,
realmente lo que hacen
the
es que
majority
no
of age is
autorizan
18
esos
years,
seguimientos.
that they
Entonces,
don't
esos pacientes
authorize this
muchas veces
follow-up,
quedan
so
como
these
volando
patients
porque no hay
are
una transición
left
conjunta. Entonces, esa es una barrera muy grande.
somehow
Y
unattended.
además porque
And
cuando, por ejemplo,
also
llegan casi
because
la mayoría de
when
edad y los empiezan
they
a poner
arrive
a
near the
tratar de
majority of
hematología
age
pediátrica, pero de
and
pasar a
they start to be
hematopatología de
treated
adultos, eso hay que
from
tener un poquito de
pediatrics
paciencia.
to
Es
adults,
muy importante que ojalá
it's
continuaran
very
con
important
tratamientos
that
pediátricos
they
porque ha
should
demostrado mayor
keep going with
efectividad, pero
pediatric
no es
treatments
fácil
because they
precisamente por
have
esa
proven to
parte
be
de la
more
barrera. En
effective, but
Colombia, por la
it
mayor
hasn't been
autorización y la
pretty
parte
much for the
administrativa
part
es muy
of
difícil.
authorizations and because of the administrative barriers in Colombia that have made this so tough. Yes, thank you so much. We've observed particularities for this population and the transition of hemato-oncology, pediatric hemato-oncology for kids. Last and not least, for kids is not easy, and for families even less, because they are accustomed to a different handling. And so how we deal with adults and with kids with these equipments are very old-fashioned, and we treat them as kids, and they're not kids anymore. And when they move to adulthood, where things are so different and volume is so big for them, it's also an important clash. Yes, thanks so much for your input and the context. We have a question in the crowd. Do we have a question? Good afternoon. My question is directed to Sarah. I would like to know a little bit more. I understood that you perform a certain validation scale of the navigation instrument within the institution where you were treating these patients. I would like to know what were the mechanisms that you used. I think I understood this, that you had a validation scale of the navigation. Maybe I didn't understand well, or what was the situation in the face of the application of such a scale. No, maybe I didn't explain myself. It's not a scaled navigation, but before starting navigation, it is important to define what we are to measure, where we want to get, and what we did was to develop certain tools and instruments. That instrument may take an hour and a half. We apply other validated instruments, psychological well-being, scales of knowledge of HIV, of hepatitis, because if we don't do it like this, it will be tougher to measure whatever change may appear before and after the intervention. This is what we did.
Yo una pregunta.
I have a question.
Desde que yo
Ever since I started with this foundation, and when I was certified, I have some sort of a guideline as I was taught in the certification. My question is, in reality, to Lamis, because I've seen or heard that they've changed, or the name, or a different adjective. It's not only been spoken of as a patient navigator, but well-being and other second names. Is it feasible? Because, for example, as I was telling you, as I was telling before, one of the teachers, I'm in the political area, and my teacher knows this. It has they haven't allowed me, anybody else, to be involved with the point that I was taught in the certification. And so I don't know if it's feasible in reality to run these modifications, because if it is feasible indeed, I believe that I am falling short, that I can access the government. I wouldn't want to do it because I've always had partnerships with privates, with companies, with labs, with hospitals, and now with FUCAM, for example, which is a very big foundation in Mexico, and they just got stripped of the government funds. And so it's unreachable now of the ones that are carrying out the process. So I asked if it's feasible, because I would have taken the support that each of the people that are next to me gave to me. In my example, I'm not a nurse, I am not a doctor, I am a lawyer. And throughout the time of the process, because I am a breast cancer survivor, in the time that I had my chemos, I got my second licensing degree in psychology and then in oncological thanatology. And if it's feasible to do it, I would tell my teacher, Have I been able to help a great deal of people? Yes, I've helped many people with foundation. I don't know if it was feasible, but I had never done this before. So I asked this. I don't know how feasible is this regard. Is it allowed?
Gracias por la pregunta.
Thanks for the question. What the situation is, to give you a little bit of context, the program of well-being navigators is right now a part of the health secretary of Bogota. But in this moment, like Alejandra was saying, that we are going through some important storms in our Colombian health system. And these storms that we are experiencing right now have a direct impact on the program, because it's a orientation and not a national bill. Yes, this is the same case in Mexico, but I'm make part of the board in Morena, and the Green Party, which is the alliance of the government right now. So is it feasible? My question is, if it's feasible. Regarding the model that you pointed, I don't know here in your country, or if the patient navigation allows it for me to apply it in my country. No?
Si nosotros nos vamos al origen,
We go to the origin. Harold Freeman said that it was not possible for the system to kill more African American vulnerable female than cancer. So that system is associated to the determining health inequalities, that system of exclusion, of discrimination. And so I believe that this is a great opportunity to, of course, keep respect guidelines of clinical navigation, but it is very important to invite everyone to complement, to go in more depth, to broaden the spectrum of navigation and the scope of navigation, thinking more in a key of health and well-being. And it means how we can manage these day-to-day cases, but how can we have palpable advocacy in structural changes that improve equity and the system. And if you allow me, we are seeing that to guarantee sustainability of well-being navigators is somehow, as Mario Benedetti's poem would say, tactic and strategy, which would be the contrary. That hopefully they won't need us someday, because we generate efficiencies, we generate profit, and being sustainable means that we have the capacity to find where we will connect, where we will improve, and of course, transfer capacities to the communities. That is our main challenge. Thank you so much, Alejandra. I don't know if with the intervention that Clara had, did she answer your question? Okay. Professors Vivian, Sarah, and Dr. Alejandra, believe that the experiences that you have shared with us are very interesting. I believe that in whatever context, even if it's the academia or from the guidelines of the health secretary, from the government, we have very interesting experiences that adapt to a specific context. And if you have realized to perform navigation, everybody is at the same. You need to identify your patient's needs, and from there you generate the strategies. So this allows to be 100% pertinent to what our populations require. You are very kind. Thank you very much for your participation. And with this, we would wrap it up. Thank you very much. Thanks so much.
Muchas gracias.
Thank you very much. And I would like to leave you finally with Minerva Grullón, who will close this first day of the event. Let me remind our speakers that we expect to see you upstairs in this same building. Thank you very much. Dear participants and speakers, Thank you so much. We've reached the end of our first day of this second Patient Navigation Congress. This is very gratifying. We are tired, but gratification is everywhere. We've shared knowledge and inspiring stories that reflect our commitment with the health of our patients. I invite you to keep together in this important journey towards the improvement of navigation of our patients. I'll see you tomorrow at 8 a.m. local Colombian time, and we invite our speakers, please, that we will see you after we are done in the 9th floor of this building as soon as we are done. Have a good night. Thank you so much. And thanks once again.